Three, two, one. We are live now, sir. We can start.
Good evening, everybody. Myself, Dr. Vishal Dave. I'm gynecologist and medical advisor to Intas Pharma. On behalf of Intas Pharma, I welcome you all for this 30-second web episode of Synergy on the topic decoding endometriosis. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal OBGYN Society. She is Founder-President of ISOVAP Chapter of Bhopal. She is National Executive Member of ESAR. She is Joint Secretary cum Joint Treasurer of MPIIG. She is Coordinator of Foxy Infertility Committee. She is Convener of the present Synergy Club Series as well as she was the Convener of Perfection Series and Symbiosis Series. Over to Dr. Monica Singh.
Thank you so much, Dr. Vishal. And today we bring greetings from Synergy Club to the great state of Karnataka and Kasoga, and with many friends from Hisar. Dr. Madhuri Patil is there, and so many friends from Hisar have helped me form this webinar. So today we present before you the 32nd episode of our very beloved program, The Synergy. And this is in association with all the zones of Karnataka societies. And it was a great pleasure connecting with all of them and talking to them, inviting them, formulating this program. So we have from North Zone, Ballari.
Monica, you're muted.
Sorry. So I think I'll start. From North Zone of Kasoga, we have got Ballari, Basava Kalyan, Bidar, Kalaburgi, Raichur, Vijayanagara, and Vijaypura. From South Zone of Kasoga, we have Bangalore, Chikkaballapur, Chitradurga, Mandya, Mysuru, and Tumkur. From Northwest Zone, we have got Bagalkot, Belgavi, Davangere, Gadak, Haveri, and Hubli, Dharwad. From Southwest Zone, we have got Chikmagaluru, Hassan, Mangaluru, Manipal, and Shimoga. So we welcome all dignitaries, and today it is my extreme pleasure and privilege to have Padma Shri Dr. Kamini Rao Madam amongst us as our chief guest. We will introduce Madam when she joins. We have her blessings with us. And now I'd like to invite the Foxy dignitaries for today. Dr. Vishal. We have amongst us Chairperson ICOG, Dr. Sheila Mane Madam. We have Vice President South Zone Foxy, Dr. Vidya Thobi Ma'am. We have our Vice President-elect South Zone Foxy for 2027, Dr. Shobha N. Gudi, who is also the Secretary General of Kasoga. We have Dr. Rekha Rajendra Kumar, who is Chairperson of Foxy Medical Disorders in Pregnancy Committee, and Dr. Bharti Rajshekhar, who is Chairperson of Foxy Perinatology Committee. I would like to extend a bouquet of welcome to each one of the dignitaries. Dr. Sheila V. Mane, we all know her as a leader who is leading ICOG so beautifully. She has held various posts in Foxy. In all the posts, she has excelled, and she is readily available to all of us who want to approach her for her blessings, for her guidance, for her mentorship. I have encountered her on so many situations. She always takes out time for academic activities, for programs. And as of now, Madam is traveling in the car, but she has joined. So, Madam, a few words of blessings from you. We are honored to have you amongst us.
Good evening, everybody. And I'm really happy to be there as a, I think, guest of honor for this program. And I would like to congratulate Monica for bringing all the societies of Karnataka under one roof. And I think it's like a revision when I was seeing everybody's picture there. And I think the webinar has given us such a good opportunity that we all can get connected to each other, and that too for nothing else but academics. And I know that today's program is very well structured, and we have all the stalwarts. I think we saw Dr. Pratap Kumar, Dr. Madhuri Patil, and we also have Dr. Mahesh, Dr. Rekha, Dr. Shobha, Dr. Bharti, everybody. I think all are participating. So it is really nice to see. And today's topic is again very interesting because we know that endometriosis is the enigma nowadays. I can see that diagnosing and then management. So I think today's program covers everything: medical management, surgical management, as well as there is a panel too. So I think somebody's background there is a noise. Somebody has to.
Support team, please
mute.
mute everybody.
Okay, so once again, I would like to congratulate and I wish her best of luck in her future endeavors. And Dr. Monica, I know that it's very nice to connect with all the societies of the different states, and everyone comes to know each other in a better way in an academic platform. So thank you very much once again for inviting me. Thank you and all the best.
Thank you. Thank you, Sheila ma'am. Thank you so much. And now we would like to invite amongst us the Foxy dignitary, Dr. Vidya Thobi ma'am. Dr. Vidya Thobi ma'am is also in a bit of a travel, so she will be joining a little later. So I will introduce madam that time. Dr. Shobha Gudi madam has joined us. We welcome madam as the Secretary General of Kasoga, a very able leader, a thorough professional, as well as very interested in extracurriculars. The fondest memories I have of Shobha ma'am are on the stage. So she brings a lot of liveliness and a lot of beauty to Foxy.
Oh,
Oh,
Monica, Monica.
madam, the
Thank
stage
you.
is all your,
Thank you
yours.
so
We
much.
welcome you from.
Thank you, Monica.
Yes,
You have brought, today so much of light and so much of camaraderie to Kasoga. We must thank you for that. And you have brought together all the societies, which is a great feat actually. Once societies are formed, they tend to work in silos, and it is only when together we want to achieve something. Somebody like you who has got a mind for uniting everybody, and everybody comes forward on the same platform to discuss a very complex subject, and that is endometriosis. I think this is a subject where questions are many and answers are actually few. And today there is so much of so many newer treatment modalities are emerging, and it is a very timely thing to bring it forward for discussion. So I congratulate you, Monica, for doing this, and I think you have a very bright future ahead of you in Foxy. I'm very keen to see you, in a higher post. All the best for your endeavors. I'm very happy that there are quite seniors are there in the faculty lineup, and I can see the former chairperson of ICOG, Dr. Lakshmi Shrikante, and Dr. Krishna Kumar, who has got so much of experience in endoscopy. And of course, you will be speaking on infertility, and Rekha will be moderating a panel on that. I can see a lot of people from Kisar, Isar also participating. So I'm very sure that, and I can see my friend Mahesh Koregal there, the president of Bangalore Society. The Lavanya Kiran also there as president of Kisar, and Anuradha as secretary. So I'm thinking that you have managed to get the best of faculty, and therefore we should not stand in the way of scientific discussion. I must say that this is the way forward, coming together and discussing more and more so that new pathways will emerge and we can have more solutions for our patients. So thank you so much, Monica. All the very best for this program. All the best to you, dear. God bless you.
Thank you. Thank you so much, Shobha ma'am. And now I would like to invite amongst us Dr. Rekha Rajendra Kumar has just suffered a personal loss. So madam will be joining a little later. We offer all condolences to her from our side. Dr. Bharti Rajshekhar is operating. So she'll also be joining later. We pay regards to them as esteemed chairpersons of Foxy. We have amongst us stars of Karnataka. So I think again, Rajshri Paladi madam is in travel. She is at present the president of Kasoga, as well as she's the person instrumental in getting me the dates of this webinar and getting all the societies together, providing me with several phone numbers and basically structuring the program. So also Anuradha. I call her Anu. Anuradha, are you there? So Anuradha is also a very close friend of mine. We are.
Hi, Dr. Monica.
Hi, who is it?
Dr. Yeah.
Madam
Since I'm
Rajashri.
Rachi, ma'am, please open your camera. We can't see you, ma'am.
yeah, as I'm traveling, the signal is not stable.
Okay. Right. We saw you,
But
ma'am.
best
Yeah.
wishes from Kasoga for you for a wonderful program. I see that you have not spared any member of Kasoga, the president, secretary, the important chairs, the past, the present, the future, and also the Kisar members. And I guess outside the official platform of Kasoga, this is the first time I'm seeing under the umbrella of a synergy program, all the members of Kasoga being present here with a wonderful structured topic. And best wishes to you and hearty congratulations for a very successful synergy program, which we all look forward to happening for the past so many years now. And consistently you have kept up the bar so high and developed the programs in a manner that each one of us could always log into whenever we seek for any queries about the particular topic, as the faculty chosen are so excellent in their field that I'm sure that they will be doing a very fantastic job. And best wishes to you and all the faculty members who are invited for this program.
Thank you, Rajshri ma'am. And I reiterate that it is because of your support and your direction that I could structure this program in such a short time. So thank you so much, madam.
Thank you. Thank you.
Thank you so much. And another star is, like I told you, I'm a little, fond of my Kisar friends, and there are so many of them. We have blessings of Dr. Madhuri Patil. I have support of Anuradha Kar at all times, Lavanya, Nivedita, Manjunath, and they are always very, very friendly and supportive. So we will wait for Anuradha to join. And now I have the pleasant duty of introducing and felicitating our guests of honor. Dr. M.G. Hiremet sir, the chief patron of Kasoga. He is right now, I think, busy in some university program. Dr. Nagaraj H. sir, I could not contact him today, but we have amongst us a very dear and my personal favorite, Dr. Professor Pratap Kumar. Dr. Pratap Kumar sir is a very close friend of myself and Dr. Randhir. He has literally guided us through our journey through ART, not since 1 year, 2 years, but decades. And people see him as a teacher, but I see him as a very, very close friend. And Pratap sir, the stage is all yours. I mean, I'm really indebted to you that you could take out time to join this program. Namaskar, sir.
Yeah,
Namaste, namaste, sir. Namaste, sir.
Namaste, all of you. Thank you very much for the invitation, Monica, and of course, Randi is there. I agree with you that we have more of friends from so many years, and I've been watching you and Randi so active in all the activities of Foxy, Kisar, Isar, everything. I think you're one of those bright couple from Bhopal, and I'm glad you're the president of Bhopal Society. And you've chosen a very tough subject, endometriosis. I always say it is a demystifying endometriosis or decoding. It is quite a tough topic. But one thing is for sure, we should not delay the diagnosis. That's what your whole program is for today. The pain which they suffer, absenteeism from school, absent from work, is a sign of endometriosis. There is no need to prove somebody has endometriosis by any other method. Long back, we were taught that biopsy has to be done for endometriosis. We don't do. Even if you don't find a cyst, but the symptoms are present, just the ovary adherent uterus may be a sign of endometriosis. I'm sure all these will be discussed today. How not to delay the diagnosis, how not to do the unnecessary things for endometriosis. Wish you all the best, and thanks for inviting me.
Thank you. Thank you so much, Pratap sir.
Thank you, sir. Thank you, sir.
Your words and your presence really are very meaningful for the, success of this program. I'm indebted to you for your presence, sir. I now have the pleasant duty of inviting our own Senior Vice President Isar and President-elect of the Indian Society of Assisted Reproduction. If there is anything under the sun we want to ask anybody in ART about, it is Dr. Madhuri Patil, ma'am. Madam, when you have taken panel discussions and talks in Synergy, they have got so many views, so many queries, And I don't even want to start relating madam's credentials because they go into hundreds and thousands. The only thing I know is when nobody knows anything, Madhuri Patel madam knows it. So, madam, we are indebted to you for sparing time. I know you find these functions very boring, madam, but I am so grateful you have joined. And I think endometriosis is one topic you're very passionate about apart from fertility preservation. So, ma'am, your thoughts on this and this program. Thank you, ma'am.
Thank you
Welcome,
very
ma'am.
much,
Welcome, ma'am.
Nika and Randi, for inviting me here. And I wish you all the success for this program. And we know that today endometriosis still remains an enigma, and there are so many changing trends now in the diagnosis as well as management of endometriosis, and also its association with infertility and how a reproductive endocrinologist looks at the endometriosis. And I'm sure all the three talks which are there would really enlighten all the delegates. And also, I congratulate you on bringing the entire Karnataka under one lens and have all of them over here. So, wishing all success for this program. Thank you.
Thank you. Thank you so much, Madhuri ma'am. And we wish to have more and more insight into endometriosis with your vision for, the future of the treatment of endometriosis. We would like to have your inputs. If you could join in between the program and after the talks, give your expert comments. We'll be really obliged, madam. Thank you so much. And our guests of honor are also Dr. Shanta Durge ma'am. Is she there? Madam is very, very active in ICOG and president of Basava Kalyan OBGY Society. She is a guest of honor. We pay regards to her. Dr. Kasturi V. Donimat ma'am, she is past president of Kasoga and she is our guest of honor for today. And now we move on to our experts. Our experts are Dr. Shobna Patel, senior dignitary from Kasoga, Dr. Devika Gunashila, whose name is equivalent to advancements in ART from Karnataka, Dr. Manjunath CS, who is another past president of Kasoga, and Dr. Lavanya Kiran, who is past president of Kisar, and Dr. Lavanya Kiran, who is the present president of Kisar. Dr. Lavanya Kiran is a close friend, a renowned ART specialist, a brilliant robotic surgeon, and a great human being. Lavanya, the stage is all yours, and we are grateful for your presence.
Thank you, Monica. We are so happy with all the work that you're doing. Wishing you a great luck. We are with you.
Thank you, Lavanya. That was very, very short and sweet. So thank you so much. And we would like your inputs in the program as and when you can join. And now
100% we are here.
Thank you, Lavanya. And now we have a special guest, Dr. Suman Gaddi ma'am. I have just talked. Madam, welcome. Good evening, ma'am. Madam is the president-elect of Kasoga. And I had the good fortune of inviting her personally, and she has accepted our invite. Madam, a few words about the program, the topic, and your vision of Kasoga as the president-elect.
Yeah, good evening, one and all. And it is so wonderful to see all 24 societies of Karnataka participating for this webinar. And thanks for uniting all of us. Today's subject on endometriosis, we are just waiting for the talks from our experts from Karnataka, and all the very best for your future endeavors and for this webinar. And my future vision, of course, it is, of course, uniting all the 24 societies as you are doing, and put up programs such so that we can all be under one umbrella, and of course taking care of doctors, patients, as well as the public. That is our vision, and the same vision was there for Dr. Durga Das also when he was the president of Kasoga. And of course, it was a great time. And thank you for inviting me for this webinar. Thank you so much. And thanks for this felicitation.
Thank you. Thank you, Dr. Suman ma'am. I'm sure Kasoga is going to reach even greater heights of able leadership. And now I have the pleasant duty of introducing Dr. Durga Das Asrana sir. Sir is the past president of Kasoga in the years 2026. He is also the past president of Tumkur OBGY Society, associate professor in Siddharth Medical College, Tumkur, and very active member of IMA, IM, as well as ISOPAP. We welcome you, Durga Das sir, and we wish you all the best for your endeavor as chairperson in Foxy, your election in Foxy.
Good evening, Monica. At the outset, I congratulate Monica and Randir for your wonderful work. 30-second episode, unbelievable. It's a real perseverance and meticulous work what you are doing. Hope it continues. Wish you all the best. Outset, Kasoga welcomes Lakshmi Shrikanda Madam and Krishna Kumar. You are the guest of Kasoga today because of Monica. Monica, you have done a wonderful job bringing all the 24 societies together. And I wish you all the best for the future endeavor. We are all with you. Thank you, both Randir and Monica.
Thank you, Durga sir. Thank you, Durga sir.
All the best.
Thank you so much, sir,
Thank you
for your gracious. We have amongst us our guest of honor, Dr. Kasturi Donimath has joined. Madam is the past president of Kasoga. Ma'am, kindly unmute and we would like to have few words of blessings from you, Madam. Madam is director of Tattva-Darsha Hospital, Hubli, past president of Kasoga, ex-HOD of the Department of OBGY at KIMS, Hubli, ex-president of HDOGS, and held several important posts as principal.
Yes, very happy.
Welcome, madam. Welcome, ma'am. We would like to have words of blessings from.
Thank you so much. Yeah, thank you. Thank you. Yeah, thank you so much for inviting me to be a part of this program. Very excellent program. You are doing 30-second synergy program. Excellent. Words of I have fall short of words to praise your efforts and your endurance. And today's topic is also very good. The need of the hour for everybody because we left and right every day we are seeing endometriosis. So how to properly manage them is the need of the hour. And so much thank you very much to inviting me. Yeah, I'm little the time this thing is different because I'm out of country. But hats off to you, Dr. Monica, and all the best for you. We assured for you. All the best for you.
Thank you so much.
I'm audible, na? There is some network this thing. Because
you can see the bright light of UK from behind your window. The typical
yeah.
Summer afternoon.
Yeah, so there was little network. Yeah.
Yes, madam. Enjoy. Thank you so much for
joining. Good sunshine here.
Yes.
Yeah. Thank you. All the best. All the very best.
Thank you, madam. We have the star has joined. So Anuradha, please do join us and do grace the function. And we would like to have your opinion, your words about endometriosis. Anuradha is the very, very dynamic secretary of KISAR at present, secretary of the ART committee of Kasoga, as well as a managing committee member of ISAR. Always thinking about fertility, how to improve fertility services, how to improve teaching. She has a very soft corner she writes beautifully about her travels. She writes a lot of nice blogs on Kashmir, I've seen. And she is a proud KGMCite, a very nice friend of mine. Anu, the stage is all yours, dear.
Good evening, everyone. Sorry, I was a bit busy. Thank you so much, Monica, for inviting. And as always, Kasoga is our the real hero here. We all are proud Kannadigas and we are all part of Karnataka Obstetric Gynecology Society. And with the able leadership of Rajshri ma'am and Shobha Guri ma'am as secretary, we are doing a lot of programs here. And Monica, it is a privilege to be present here today with all the stalwarts. And thank you and all the best for your future, whatever you have taken. Thank you so much.
Thank you, Anuradha.
Thank you, Dr. Anuradha. Thank you.
Radha Khar was instrumental in providing me the direction and structure of this program. along with Dr. Rajshri Paladi, ma'am. Thank you, Anuradha, for all your hard work and your guidance. Thank you so much.
Thank you.
I would like to now invite our special guest, Dr. Shilpa Harish. Dr. Shilpa Harish, along with Dr. Anuradha, she is actually the chairperson of the ART committee of Kasoga. I'm really surprised at the way Kasoga and Kisar work. It is like almost like a mini India. They work in so much of coordination and there are so many programs that I was not able to get one date for this synergy, you know. With great difficulty, I got today's date. So, Shilpa ma'am, I'm so grateful to you for your presence. I think ART Committee of Kasoga must be doing a wonderful job under your leadership. And the stage is all yours, ma'am, for your words, please.
Thanks a lot for inviting me, Dr. Monica, Dr. Ranveer Singh. It's a fantastic program. I'm following your synergy episodes. You are doing a wonderful job. All the best for your future tenure also. Hearty congratulations.
Thank you. Thank you so much, Shilpa ma'am. And I thank my co-convener, Randeep. I would like to thank the executive members of Kasoga who are heading the zones. I don't know whether they are present, but we have Dr. Sanjana Tallur Patil, who is the North Zone executive member. Dr. Rekha Rajen Kumar will be joining a little later. She is the executive member responsible for heading the South Zone. Dr. Soumya Mani heading the Southwest Zone, and Dr. Asha Lata Mallapur heading the Northwest Zone as executive committee member. We thank them for their cooperation and their for participating in this program. And now, without wasting time, we would like to now introduce and pay individual thanks to all presidents and secretaries of all the 24 societies of Kasoga. So we are going strictly according to the zones. We are going according to the zones, Dr. Vishal? Okay. So we have Ballari OBGY Society. We thank President Dr. Jyoti Patil Madam and Secretary Dr. Anupapa Sundar. We have Basava Kalyan Society. We have President Dr. Shanta Durge Ma'am and Secretary Dr. Priyanka Varvatte. We thank them. Bidar OBGY Society headed by President Dr. Jayashri Swami Ma'am and Secretary Dr. Savita Badigar. Kalaburgi OBGY Society headed by President Dr. Lakshmi Harshangi and Secretary Dr. Madhura Banale. Raichur OBGY Society headed by President Dr. Ranganath S. Sir and Dr. Raju B. Geradi as Secretary. Vijayanagara OBGY Society headed by President Dr. Sumangala Devi, Secretary Dr. Tanuja Hubli. Vijaypura OBGY Society headed by President Dr. Jyoti Korbu and Secretary Dr. Mamta Kuloli. Bengaluru OBGY Society headed by President Dr. Mahesh Korigol Sir and Secretary Dr. Vijay Kumar CR Sir. Chikkaballapur OBGY Society headed by President Dr. Anita D, Secretary Dr. Sushma S. Chitradurga OBGY Society headed by President Dr. Lata MG and Secretary Dr. Soumya S. Mandya OBGY Society headed by Dr. H.C. Savita as President, Dr. Shilpa MNS Secretary. Mysuru OBGY Society headed by Dr. A. Sonia Mandappa Madam and Secretary Dr. Sindhu Lakshmi D. Tumkur OBGY Society headed by Dr. S. Baswaraju Sir and Dr. Jeevan Reddy. Bagalkot OBGY Society headed by President Dr. Viresh Nagathan and Secretary Dr. Manohar Tankasali. Belgavi OBGY Society headed by President Dr. Mrityunjay Bellard Sir and Secretary Dr. Rajeshwari Patil. Davangare OBGY Society headed by President Dr. Madhu K.N., Secretary Dr. N.R. Divakar. Gadag OBGY Society headed by Dr. Sapna Kalia as President, Dr. Shilpa Duduti as Secretary. Haveri OBGY Society headed by Dr. Vaishali Pandit as President, Dr. Pradeep Basalihalli as Secretary. Hubli Dharwad headed by President Dr. Prakash Biranur and Secretary Dr. Pooja Patil. Chikmagaluru OBGY Society headed by Dr. Anuradha B as President, Dr. Gitanjali G as Secretary. Hassan OBGY Society headed by Dr. B.A. Vishalakshi as President and Dr. Purnima Manu Prasad as Secretary. Mangaluru OBGY Society headed by President Dr. Ravikant G.O. Sir and Secretary Dr. Ramya N.R. Manipal OBGY Society headed by Dr. Raja Lakshmi Madam and Dr. Indra Pai Shanbag as Secretary. Shivamoga, also known as Shimoga OBGY Society headed by President Dr. Veena S. Bhatt Ma'am and Secretary Dr. Swati Kishore. My program coordinators are two very able gynecologists, Dr. Purva Bhatkur, who is a very hardworking OBGY associate professor in GMC Bhopal, Dr. Virul Shivastav, she is a fertility specialist practicing in Bhopal. I thank them for their hard work, along with Dr. Vishal Dave. So that brings us to session 1. Dr. Lakshmi ma'am is waiting since a long time. It's 33 minutes past 5. And that brings us to the formal introductions are over and we can start session 1. Purva, are you there? Virul, are you there?
Ma'am, I am there.
Okay, Purva, please start session 1, please.
Yes. So moving to our first academic session, that is medical management in endometriosis. I invite Dr. Mahesh. Welcome you, sir. We have with us Dr. Anita D. Madam. Madam is presently President of Chikaballapura OBGY Society. We welcome you, ma'am. We have with us Dr. Latha M.G. Madam. Madam is presently President of Chitra Durga OBGY Society. We welcome you, ma'am. We have with us Dr. H.C. Savita Madam. Madam is presently President of Mandya OBGY Society. We welcome you, ma'am. We have with us Dr. A. Sonia Mandapa Madam. Madam is presently President of Mysore OBGY Society. Welcome you, ma'am. We have with us Dr. Basava Raju sir. Sir is presently President of Tumkur OBGY Society. Welcome you, sir. We have with us Dr. Jyoti Patil Madam. Madam is presently President of Ballari OBGY Society. We welcome you, ma'am. We have with us Dr. Jayashree R. Swami Madam. Madam is presently President of Bidar OBGY Society. We have with us Dr. Lakshmi Harshangi Madam. Madam is presently President of Gulbarga OBGY Society. We have with us Dr. Ranganath S. Sir. Sir is presently President of Raichur OBGY Society. We have with us Dr. Jyoti Korbu Madam. Madam is presently President of Vijayapura OBGY Society. We welcome you, ma'am. We have with us Dr. Suman Gala Devi Madam. Madam is presently President of Vijayanagar OBGY Society. We welcome you, ma'am. We have with us Dr. Anuradha B. Madam. Madam is presently President of Chikamangaluru OBGY Society. We welcome you, ma'am. We have with us Dr. B. A. Vishwalakshmi Madam. Madam is presently President of Hassan OBGY Society. We have with us Dr. Ravikant Geo Sir. Sir is presently President of Bangalore OBGY Society. Now I hand over the session to our chairperson to introduce our speaker, none other than Dr. Lakshmi Srikhande Madam.
Dr. Sonia Madam, are you there? Dr. Sonia Mandapa ma'am?
Yes, very much, yeah.
And please do the honors of introducing our first speaker, please. Can you see the CV slide, Madam? Sonia ma'am?
Yes. Privileged to introduce Dr. Lakshmi Srikhande, the entire Foxians. And I think outside Foxy also, there are a lot of people who are, in fact, looking forward to listen to Madam's talk. That's what I've been knowing about. But before I introduce, I think just a note on the synergy, which is an art of achieving more together than alone. And Monica, yourself exemplifies this through your ability to unite. Your inspiration and your leading capacity has actually led this synergy to greater heights with a combined effort. All the very best. And thanks so much. And yes, it is more than 30 minutes. I think Dr. Lakshmi is waiting, and we are also waiting for her deliberations. Madam is a Foxy representative to a FOG. We all know that she was a committee member for climate change and toxic environmental exposures, 26 to 28, and this has kept us going. I think there's many more to learn from this committee. She was a vice president, National ISOPAB, president of ISOPAB Vidarbha chapter, and chairperson of Indian College of OBG and 22-23, national corresponding editor Jogi, and national corresponding secretary of AMWI,
member of Suffolk Education Committee, Joint Secretary of Indian Menopause Society, and Chairperson of Medical Educational Society, and President of Menopause Society at Nagpur, and Senior Vice President of FOXY 2012. And 2012, we still remember the Vice President post, Madam. We witnessed how the deliberations were on, and you kept the team going. And she was the chairperson of HIV/AIDS Committee, FOXY, President of Nagpur OBG Society, 2005-2006. She is recipient of various awards and recipient appreciation letter from Maharashtra government for her work in the field of Save the Girl Child. And she set an example for so many junior OBGYNs. She's also received the Bharat Excellence Award for Women's Health. She's delivered more than 550 guest lectures with 32 orations in her list, more than 62 publications, national and international publications, and conducted TOTs for 1,000 school teachers on adolescent health issues. It is indeed a privilege to listen, and we Kasogans in this platform are looking forward for your deliberations, Madam. Over to you, Madam.
Thank you. Thank you so much, Sonia, for such wonderful words and kind introduction. And Monica, I must say that this is Monica's energy is equal to synergy. Your hard work, dedication, and I mean, really, I admire the way you connect and bring all these stalwarts under one roof. Hats off to you. And I was
Thank you, ma'am.
really
Thank you, ma'am.
enjoying your introductions and the inauguration ceremony. Thank you for making me part of your synergy program. And I know I am the opening batsman for today's CME, that is your decoding endometriosis. Is my slide visible? Hello?
It has started to, yes, Madam.
Now you all can see?
Yes, Madam. You can make it full screen. Yes, Madam.
Yes, yes,
Yeah,
ma'am. It's visible.
yes.
Yeah, visible.
Yeah. So let us know about the endometriosis so that we can cover all the three topics: medical management by me, infertility by Monica, and the surgical management by Dr. Krishna Kumar. So we all know that presence of endometrial tissue, that is both glands and stroma outside the uterus, is endometriosis. This tissue is morphologically and functionally similar to the endometrial tissue, and this responds to hormones in cyclical manners. Endometriosis is characterized by chronic pelvic pain and infertility. It affects 45 to 82% of women with chronic pelvic pain and as high as 35% women who are suffering from subfertility. They are having endometriosis. They are suffering from endometriosis. So when we have a look at the disease burden, that is endometriosis burden, 10 to 15% women of reproductive age group are suffering from endometriosis. Asian women were reported to have a higher prevalence of endometriosis than Caucasians, and nearly 1/3 women who have endometriosis, they are suffering from moderate to severe endometriosis. Various studies which are conducted in Indian population have shown the incidence of endometriosis to range from 34 to 48% as diagnosed by laparoscopy. So this is the definitive diagnosis prevalence which I am talking. When it comes to etiopathogenesis, we all know that there are many etiopathogenic factors which are responsible for endometriosis. It can be because of retrograde menstruation, where endometrial tissue gets implanted in peritoneal cavity. We have genomic alterations therapy. We have epigenetic theory. It can be because of the iatrogenic spread when we are doing laparoscopic surgery. So the theories are many. Let us come to the risk factors. The risk factors for endometriosis are early menarche, when the first degree relative is suffering from endometriosis, late menopause, low BMI, Mullerian anomalies, nulliparity, prolonged menstruation, that is, if the menstrual cycle is lasting for more than 5 days, shorter lactation intervals, shorter menstrual cycles, and the ethnicity, the race also matters. It is more seen in white race. These are the various sites of endometriosis. It can be pelvic, extrapelvic. We do have less common site, and rarest site, it can be seen in extremities as well. As gynecologists, we are more concerned with the pelvic sites. So the sites for endometriosis can be in the ovary, cul-de-sac, uterosacrals, posterior surface of uterus, posterior broad ligament, rectovaginal septum, and tubes and round ligaments. Symptoms are variable. Sometimes they can be vague as well. But the most common symptoms with which a woman comes to our OPD is basically dysmenorrhea, infertility, vaginal bleeding between periods, that is intermenstrual bleeding, painful urination, painful defecation, HMB, that is heavy menstrual bleeding. Severe fatigue can also be a symptom of endometriosis, dyspareunia, and diarrhea, constipation, nausea, or lower back pain. So you can see endometriosis is a complex disorder affecting both physiological and psychological well-being of women. Now coming to the diagnosis, as Dr. Pratap Kumar was also talking about the diagnostic delays. Of course, whenever any woman coming to us with the symptoms, we have to take history in great detail. In history, you have to ask about the details of menstrual history, and you have to ask about whether this pain is cyclical or non-cyclical. Pelvic examination should always be first by pars speculum, then by pelvic examination. Don't forget to do posterior fornix palpation. Then comes the role of transvaginal ultrasound, where the sliding sign will give you lot many information as far as endometriosis is concerned. Not all patients, they require advanced imaging techniques like your CT MRI. This can be reserved for the selected cases. Now, what is the role of laparoscopy? The older school of thought was laparoscopy is the gold standard for diagnosis. And if you are doing laparoscopy, don't forget to take a biopsy and confirm it by histology. But now, no more. The ISHRAE's latest guidelines are telling us that laparoscopy is recommended only if your transvaginal findings are having negative results or where you have started empirical treatment and it has failed. So in these cases, you can go ahead and do laparoscopy. Even in adolescents, if you are suspecting endometriosis, imaging is negative, you have treated her empirically with medical managements and it's not successful, here in these cases, you can consider diagnostic laparoscopy. And if you are performing laparoscopy, should consider taking biopsy to confirm the diagnosis histologically. Although you must remember that negative histology does not entirely rule out the disease. Now, whether you have confirmed the diagnosis by laparoscopy or where you are just suspecting the diagnosis on the basis of her clinical signs and symptoms and on the basis of your transvaginal ultrasound. What is your treatment goal? It is to create an acyclic hypoestrogenic environment. And how you can create this environment? You can create it either by locally inhibiting estrogenic stimulation, that is by progestins or OCPs, or you can block ovarian estrogen secretion by GnRH agonist and antagonist. So this is the treatment algorithm given by our own Foxy when you are managing the patients with pain symptoms and you are suspecting that this could be endometriosis. You have to pursue the first line medical therapy. If your patient responds, continue the therapy. If there is no response, then you have to consider the second line therapy. If with second line therapy there is no pain relief, you have to consider the surgery. And when you can consider medical therapy once you have done with the surgery, if you want to prevent recurrence for patients who have residual disease after your surgery, and in case of recurrence, there is a role of medical management after your laparoscopic surgery. This is another algorithm which you can follow. You have to ask if your patient is wanting the pregnancy. You have to ask it, and if she's saying yes, I'm keen to get pregnant as early as possible, you have to go ahead and do the fertility treatment. She is saying yes, I want to become pregnant, but not immediately. In these cases, you can start her on COCs, progestins, or second line therapy, that is GnRH agonist and antagonist as well. If she is saying no, I am not interested in fertility at all, then also the treatment is medical management, either first line or second line. If she is not responding to your first line, you have given second line, then of course you have to go ahead and consider the surgical treatment in these women. Now, whether you should choose medical management or surgical management, remember, we always say that it has to be a shared decision-making approach. You have to take into consideration individual preferences, the side effects of each approach, the individual efficacy of each treatment approach, the cost involved, and you have to take into account the availability of that treatment approach in your facilities, and accordingly, you have to discuss in great detail with the patient, with the husband, and sometimes with the family as well, whether you all want to go ahead with medical management or surgical management. This is the concise slide which I have put you for the medical management of endometriosis. We start with NSAIDs. It is non-hormonal. You can give diclofenac, ibuprofen, or mefenamic acid. This is a symptomatic treatment. You can give it either alone or in combination with other treatment to relieve the dysmenorrhea associated with endometriosis. There is no effect on the progression of disease. The first line hormonal treatment starts with COC. You can give desogestrel and ethinylestradiol or norgestimate and ethinylestradiol. Remember, it is used in the treatment of endometriosis related pain. It can be considered as a first line treatment in adolescents, and when you are choosing OCPs, the continuous use is preferable as compared to the cyclical use. Next first line treatment is progestins. We have LNG-IUS, medroxyprogesterone acetate, cyproterone acetate, norethistone acetate, and Dynogest. This is again effective treatment for pain. It is first line, and you can give Dynogest up to 52 weeks. GnRH agonist is a second line medical management. We have leprolide acetate, triptorelin palmorate, and goserelin acetate. This is injectable. It is given for pelvic pain associated with endometriosis. This is agonist, so you have to give add-back therapy, and you can give it maximum for 3 to 6 months. GnRH agonists are now available in our armamentarium. We have elagolix, relugolix, and linzagolix. This has the advantage of oral medication, and this is a second line treatment. We also have aromatase inhibitors, but that is third line treatment. You can give it anastrozole or letrozole. But few societies agree that it could be a second line treatment as well. It is not FDA approved, and it can be used in drug-resistant rectovaginal endometriosis. This is another algorithm which can be used if you are going to treat according to the site of the endometriosis. That is whether it's peritoneal or ovarian or deep nodular endometriosis. If it is peritoneal endometriosis, again, the choice of treatment is OCP or progestins as a first line. Next line is elagolix, not responding, go to surgery. If you are treating her as ovarian endometrioma, if it is less than 3 centimeter, then the treatment is as per the peritoneal endometriosis. But if the endometrioma is more than 3 centimeter, then in these cases, you can prefer surgery over medical treatment. In cases of deep nodular endometriosis, if it is less than 2 centimeter, you can give a trial of elagolix in these cases. Also, if your deep nodular endometriosis is more than 3 centimeter also, you can give her trial of elagolix before considering surgery in these cases. Now let us know the limitations of NSAIDs and combined oral contraceptive pills. For analgesics, we don't have high quality studies which have been conducted in last 3 decades to support the definitive results of NSAIDs on endometrial pain. And remember, if you are giving it for long term, then do remember that they can be nephrotoxic. The drawback of COPs is that the pharmacokinetic profile has inter-subject variation, especially in metabolism arena. Metabolism of COC is hampered in obese patients, and COC has shown interaction with multiple drugs, rendering it difficult to prescribe in women with comorbidities. Also, OCP reduces dysmenorrhea by approximately 50%, but OCP has not shown any benefit for non-menstrual pelvic pain or for dyspareunia. What are the limitations of progestins and GnRH agonist? Oral progestins, they undergo high first-pass metabolism. Experimental studies suggest that metabolism may also occur at the site of administration. Therefore, it may alter the intensity of action which is required. And 1/3 patients are found to be resistant to progestin therapy. When it comes to GnRH agonist, there is delayed response due to initial flare-up response. Suppression of estradiol occurs to less than 20 picogram per ml, which has adverse effects on bone mineral density. Your patient will suffer from hot flushes, and you just cannot titrate the estradiol levels. There is unpredictable reversibility of treatment and limited long-term efficacy. These are the recommendations by the latest ISHRE guidelines that danazol and antiprogestrogens, laparoscopic uterosacral nerve ablation, presacral neurectomy, and anti-adhesion agents are no longer included in the recommendations. It is recommended to prescribe GnRH agonist as second line to reduce endometriosis-associated pain, although evidence is limited as far as dose or duration is concerned. You can consider ADVAC therapy alongside GnRH agonist to prevent bone loss and hypoestrogenic symptoms, and the ISHRE guidelines recommends GnRH agonist as second line therapy for endometriosis associated pain. So now we have elagolix. How does it work? It causes dose-dependent suppression of estradiol. LH and FSH suppression is observed after 4 to 6 hours. Estradiol suppression is observed within 24 hours. And after you withdraw elagolix, estradiol levels return to normal within 24 to 48 hours. So when you compare GnRH agonist with GnRH antagonist, GnRH agonist, they do have initial flare-up effect. They do have severe hypoestrogenic effect, whereas GnRH antagonist, they have less hypoestrogenic effect as compared to the agonist. So the benefits of GnRH antagonist over agonist are 3. That is oral route, short half-life, and the elagolix does not block the pituitary axis completely. Thereby, it has less hypoestrogenic side effects as compared to the agonist. This is the pharmacokinetics of GnRH antagonist, that peak plasma concentration occurs within 1.5 hours. There is rapid onset of action. It is hepatic metabolism, and the half-life is 4 to 6 hours, and we have reversible estradiol suppression. Whenever we are prescribing any medicine, we should understand the drug interaction which occurs with that medicine. If your patient is taking digoxin, you have to increase the monitoring, and if elagolix is discontinued, you have to increase monitoring of digoxin concentrations again. When it comes to benzodiazepines, you have to consider increasing the dose of midazolam by no more than 2-fold. What about rosuvastatin? You have to monitor lipid levels and adjust the dose of rosuvastatin if your patient is taking this drug and you want to prescribe elagolix. If she is taking omeprazole, many patients are on this drug for the reflux and for their acidity. So when you want to use elagolix concomitantly with higher doses of omeprazole, that is more than 40 milligram OD, you have to consider dose reduction of omeprazole. And what about OC pills? You have to advise women to use effective non-hormonal contraception during treatment with elagolix and also after 28 days of stoppage of your elagolix. So this is a stepped care approach. You prescribe GnRH antagonists to those patients who fail to relieve symptoms with your hormonal contraceptives, who have resistance to progestins, and who want to avoid surgery. What are the contraindications? Very obvious: pregnancy, hypersensitivity, osteoporosis, and lactation. How you can use elagolix in special population? If she becomes pregnant, discontinue. Adolescent, we don't prescribe. Lactation, avoid. Geriatrics, it is found to be safe in the older age group. Hepatic impairment, the elagolix in 150 milligram in moderation, you can prescribe, but it is contraindicated in severe hepatic impairment. For mild to moderate hepatic impairment, with your regular monitoring of LFT, you can go ahead and give her elagolix. For renal impairment, it has to be found to be safe. Adverse effects are few. Of course, they are related to the hypoestrogenic side effects in the form of hot flushes, insomnia, night sweats, depression, and in Indian setting, you have to counsel your patient that she will not get her periods when she is on elagolix. So when to give 150 milligram and when to give 200. It is available in two strength in the market. So 150 milligram, you can give OD to those women who are suffering from dysmenorrhea and moderate NMPP due to endometriosis. Consider lowest starting dose. 150 OD can be given up to 2 years. If you want to prescribe 200 elagolix BD, then it can be given to dyspareunia or a history of endometriosis pain, which is severe enough to require opioid analgesics. You have to initiate therapy 200 BD and then switch to 150 milligram OD, and 200 milligram BD cannot be given for more than 6 months. So use of elagolix 150 QD is recommended for women with moderate hepatic impairment, that is OD, a 150 milligram OD, with the duration of treatment limited to 6 months. So if she is having mild to moderate hepatic impairment, you can safely give 150 elagolix OD for 6 months. 200 milligram BD is not recommended in cases of hepatic impairment, and no dose adjustment of elagolix is required in those women who are suffering from mild hepatic impairment. Now we have relugolix also in our armamentarium. Relugolix contains the relugolix 40, norethistron acetate 0.5, and ethinyl estradiol, that is estradiol 1 milligram. Adverse effects are same as that of elagolix. There are various studies which has found relugolix also safer in cases of endometriosis associated pain. So this is the recommendation by ISHRE 2022 that when you are seeing or suspecting endometriosis, Start with analgesics. You can give it alone or combine it with hormone therapy. COCP, yes, you can start in cases of dyspareunia, dysmenorrhea, non-menstrual pelvic pain. It is strongly recommended. Progestins, you can prescribe. LNG IUS and etonogestrel subdermal implants can also be considered. GnRH agonist is also recommended, but remember the adverse effect, that is hypoestrogenic effects on the bone and hot flushes to these patients. GnRH antagonist is also recommended as a second-line therapy, and aromatase inhibitors may be prescribed in combination with oral contraceptives, progestogens, GnRH agonist or GnRH antagonist. This is the old American ACOG guidelines, but now they have also recommended the GnRH antagonist as a second-line for treatment of endometriosis-associated pain. This is the FOXY ICOG GCPR 2024. It was released, and this was on endometriosis, where our FOXY ICOG GCPR has also recommended the use of GnRH antagonist in the management of endometriosis associated pain. Can we prevent endometriosis? As far as current studies are concerned, there are no known methods for prevention. Some studies suggest that rapid and aggressive medical or surgical therapy can arrest the progression of already existing disease, especially when you are catching hold of this disease early. Early and prolonged use of OC pills, pregnancy and breastfeeding, they seem to afford some degree of protection against endometriosis. What will go in long term is patient education. You have to stress the importance of continuous medical therapy, that is 6 months, 1 year, or sometimes 2 years. Patient, most of the times, they just expect miracles from you. If she is not getting any relief, she will start grumbling, she will change the doctor. So it is better you counsel her that this is a chronic disease. Medical therapy often relieves pain but induces uncomfortable adverse effects as well. So do counsel them about the side effects of whatever drug you are prescribing. Patient needs encouragement to complete your course of medical management. Also educate about the recurrence of symptoms. And if it occurs, they should come to you promptly for further evaluation. Also educate them about the severity of the disease, and if it progresses, that it can affect the bowel and bladder as well. So they should not take it lightly. They should be in touch with you. They should keep the disease under check, and they should not allow it to progress so that it can affect their bladder, bowel, or ureters. So the take-home message, we all know that it's a chronic disease, often underdiagnosed. You have to use your clinical skills along with transvaginal ultrasound, reserve MRI for selected patients. First line therapy is NSAID, then OC pills, progestins, and second line therapy is GnRH agonist and antagonist. Multidisciplinary care improves the outcome and do address their fertility concerns, their pain, and don't forget to take care of their mental health as well. All said and done, there still exists a large diagnostic void between the onset of symptoms and a reliable diagnosis. And as you can say, this diagnostic delay is to the tune of 8 to 12 years. And this is because of the low level of awareness on both the sides. That is, from patient side, they take pain as a very normal thing. And sometimes on our side, we also take dysmenorrhea very casually. And we don't suspect or we don't rate endometriosis empirically. But remember, behind every delayed diagnosis is a woman who waited too long to be heard. And in between, she is suffering physically and mentally. So thank you, friends. Thank you so much for your patient hearing, and for all the support, mentorship, and confidence you reposed in me throughout my journey. And I humbly seek your blessings and continued support as I strive to contribute meaningfully to Foxy and the cause of women's health in the years ahead. I am currently Foxy representative to AOFOC. So I invite you all for this AOFOC conference, which will be held in Sydney from 12th to 15th October. So if you are interested, please contact me. And as a FIGO committee member, I am inviting you all for the FIGO conference, which will be next year in Montreal from 31st October to 5th of November. If there are any questions, I will be more than happy to answer. And thank you so much for your patient hearing. And thank you, Monica, for giving me this chance to be part of your Synergy series.
Madam, we are blessed and honored to have such an erudite and elite speakers in Synergy. You don't know how much laurel and glory you have brought to the program. And of course, all the guidelines are now crystal clear to all of us.
Yeah.
We have so many dignitaries from Kasoga, and we have about 5 to 10 minutes for question answer session.
Yes.
Because our third talk by Dr. Krishna Kumar sir is slated at 7 p.m. So if there are any questions, Dr. Purva, you can invite in the chat box, and Dr. Virul, you can take the questions live over here from our chairpersons and dignitaries. Whoever wants to ask any question from Madam regarding the medical management, regarding elagolics, regarding newer molecules, newer methods of diagnostics, please do so. Madam, I will begin with the first question. Madam, you said there is a latent period of 10 to 12 years between the onset of symptoms and diagnosis. That struck me as a very, very long period. I used to think it's around something like 4 to 5 years. But Madam, does it present with then infertility when she gets married? Or does she present with some other common symptom? How does she ultimately go to a gynec?
Infertility per se is not a symptom of endometriosis, but whenever any patient comes to us with infertility and we are evaluating her and we can find endometrioma. Sometimes all endometriomas, they do not produce symptoms. They can be asymptomatic. But during infertility evaluation, we find them and we ask them the history. So they confide that, oh, I am suffering from dysmenoriasis menarche. I am taking painkillers on my own. She will also confide that she is having some kind of dyspareunia as well. And that is why the diagnostic delay is so long, because she takes it very casually. She pops up analgesics on her own and she doesn't bother to go to a gynecologist because she gets relief. And sometimes our own profession, whenever any adolescent girl comes or a young woman comes and she tells us about dysmenorrhea, we also just chalta hai, hota hai. You just take OC pills or you just take painkillers and it will be gone. But we have to take it very seriously. We have to evaluate and we have to treat her accordingly. And laparoscopy is not indicated for diagnosis. This is, again, we are emphasizing again and again that don't put in a scope just to diagnose unless and until you have treated her empirically and it has failed. Then only you are justified in doing a diagnostic laparoscopy.
Very true, Madam. In fact, I just recall in AICOG at Mumbai, the chairperson had released endometriosis guidelines of imaging in the conference, in her workshop, and that had a complete chapter in the newsletter on imaging specific to endometriosis. So imaging has become so precise that the transvaginal probe itself can give you several signs of adhesions or rectal involvement, how the bowel looks adherent, how these ovaries look adherent. There are certain planes which are lost. So there are certain signs like the beak signs, hook signs, and all those, which can, lead us towards the diagnosis. So taking this forward,
that is what, Monica, not each and every gynecologist is well versed with the detailed imaging required for endometriosis, and that is another reason for delay in diagnosis. So I would like to encourage all the gynecologists that don't hesitate to refer this patient to a center who are having a special interest in managing endometriosis. Don't do just a casual transvaginal ultrasound unless and until you know what you have mentioned so many signs, because transvaginal ultrasound itself can give you loads of information about the endometriosis. So don't hesitate. Refer them to a higher center where they are having special interest in managing endometriosis.
True, madam, because nowadays there are certain surgeons also who are themselves completely to endometriotic surgery only. Like
They do surgery only. They don't know how to diagnose only. Diagnosis is very, very important. Now you have opened a Pandora's box, Monica, because surgeons are putting in a scope. They are doing endometriotic surgery. They don't know the effects of that surgery or the after effects of that surgery on the quality of the life. They don't know about the chances of recurrence. They don't know how to manage that recurrence. They don't know how to diagnose. They have put in a scope for a appendicectomy and they have seen endometriosis or an endometrioma. They will just go ahead and they will treat it. Or if they have seen peritoneal endometriosis, they will go ahead and they will do the cauterization. So, I mean, I really don't know what to do about surgeons doing endometriosis surgery, but being a gynecologist, if you are there in that team, you should guide the surgeon what they should do, what they should not do, and you should know how to manage that patient after the surgery is over. And if you are doing surgery, please try to remove the endometriosis as much as possible. Because first surgery is the best surgery when it comes to endometriosis. Another point, not all laparoscopic surgeons and not all gynec laparoscopists are trained or well versed in managing moderate cases, severe cases, and die cases, that is deep infiltrating endometriosis. So again, take help of the experts who know and who has special interest in doing this advanced endometriosis surgery. Don't do half-hearted surgery.
Very true, madam. Very true. So we have come to a very, very controversial topic of DIE. And if there are any radiologists like ultrasound aficionados amongst us who are really doing advanced, I had Dr. Raju sir was with us, Dr. Raju Girardi, who is a renowned gynec ultrasound specialist from Kasoga, but I think he's not there in the audience right now. But we could have inputs from other dignitaries who are present, who are doing endometriosis surgery, advanced ultrasound. Madam is there to answer our questions. Anuradha Kar, would you like to put in a word? Sonia, madam?
Yeah, can I, ma'am?
Sure.
Yes, please. Yes, please.
Madam, when we have already diagnosed and we think of prescribing GnRH analogs, do you feel that knowing the hypoestrogenic state, a follow-up checklist is a must?
Yes.
Like
yes.
doing an LFT and bone
Yes,
mineral
yes, yes.
densities. Because we've been seeing after 3 to 6 months when we lose the follow-ups. So a mandate with the prescription, if a follow-up checklist is, what does the say? Hello?
Absolutely. Sonia, you are absolutely right. Because everywhere we have to have the baseline blood test, which
Support team,
includes
please mute
AFT,
everybody.
LFT.
Dr. Vishal, please mute.
Support team, please mute.
And also you have to take the history in detail. If she's already a perimenopausal woman, already having the hypoestrogenic side effects in the form of hot flushes, and you are prescribing these GnRH analogs to her, I mean, it will worsen her situations. So it is your decision, and you have to select the cases judiciously where you are going to prescribe the second line. And when it comes to second line, nowadays we all prefer the antagonist over agonist.
Agonist, yes, ma'am. Agreed.
Because it is reversible. Today only I got a patient who came to me after 2 months of taking elagolix, and she was really so much suffering from the hypoestrogenic side effect. She brought that
yes.
photo where she is drenched in the sweating, and she said, "Madam, dekho, you see how much I am sweating and all these things. So sometimes the response is patient specific as well. Another patient came after her, but she was not suffering from so much hypoestrogenic side effect. She said, हाँ थोड़ा सा गरम लगता है, but I can manage. If you want to continue, I am ready to continue. But the first patient said, no, no, no. I just can't tolerate. And both were taking elagolix from just 2 months. And whenever we are giving elagolix, we say that you can give elagolix without add-back therapy for 3 months. I mean, that is the traditional teaching we are doing. But see, I mean, both my patients today only in OPD, one was suffering from severe hypoestrogenemia and she was younger than the second patient. The first patient was just 27-year-old and my another patient was 38 years old who was having a mild thing, just some hot feeling thing, and she was not having sweating and insomnia, anything. So again, I can say that age, I mean, we can't decide on the basis of age. But we
And
are
also
very
now I
lucky.
think it's already gone to the GP's prescription, madam.
I
Because
really don't know. But we are very lucky that its half-life is very less. And once you stop elagolix, the reversible
Reversal
occurs
work.
in 24 to 48 hours. So
Yes.
whatever hypoestrogenic side effect she is suffering, I mean, after 2 to 3 days, you can assure her ki, okay, you will be all right after 2 to 3 days.
True.
And how come GPs are prescribing? I really don't know. Because after 3 months, you have to give add-back therapy.
Exactly. Yes, ma'am.
Without add-back therapy, we don't recommend. And nobody should start from 200. You have to start from the minimum possible dose, that is 150.
Yes.
Madam, I remember about 10 years back, or maybe 12 to 15 years back, when Dynogest molecule came, we started using, that was around 2012 or 13 or something. And we were very happy because the pharmacokinetics of Dynogest is there's a lot of peripheral circulating progesterone. So it affects the affected tissue, and the pain relief is like something better. Effects are almost non-existent. Then, except for a few episodes of spotting, patient has in the initial 2-3 months. So, what is the current status of Dynogest, and are we ready to abandon it in favor of oral antagonist? And just a
See,
query.
Moni, whenever any new drug comes, you all know that it is pharma driven and commercial interest takes over. And it is really being pushed like anything. Actually, LNG-IUS, if your patient can go ahead and use LNG-IUS and she is responding to LNG-IUS, nothing like that. Because OCP is oral, but here we recommend continuous dose, not cyclical dose. So LNG-IUS is first. Dynogest she can take continuously up to 52 weeks. I mean, that is 3 to 4 years. But of course, with Dynogest, you have to monitor. Some patients, they do have breakthrough bleeding, spotting in between. They do have certain problems. So what is your questions? I mean, I really don't know where antagonist will take over, because all the guidelines are telling us that GnRH analogs are second line treatment. They are not telling us to, the moment you suspect endometriosis, you are not supposed to jump and start them on elagolix. Don't do that. Start with NSAID, OCPs, your LNG-IUS or oral progestins, your Dynogest. If they are not responding to first line, then second line is recommended. And it is there in FOXY GCPR, it is there in ACOG, it is there in ISHRE guidelines.
So probably what I consider, what I think is, ma'am, practitioners today, because of, I think, insufficient knowledge or training in this field, they are jumping to oral antag a little too sooner. A tad too sooner, they are starting oral antag. This I gathered from my colleagues. When we sit in CMEs, we talk to gynecologists who are 10 years younger to us, 15 years younger to us. They are using elagolix left and right. And we are scared, we are scared to use unless it's indicated. So that
is pushed by the pharma, Monica. It is pushed by the pharma, and our young gynecologists, they are very happy that, oh, something new has come in our armamentarium. Let's use it. but they should realize that all the guidelines are telling it that it is second line. When your first line has failed, then only you are supposed to start with the second line. And I have showed it in each and every slide that it is the second line treatment, not a
Madam,
first line.
this is the most important message of your talk. I think this is, if this message goes home, that
It is second line.
so this is the most
Second line, and counsel your patients. Like I have put my patients on Elagolix. But see, I am telling you my practical first hand experience of two patients who were taking Elagolix from last 2 months. So what happens after Elagolix? Again, I am trying. I told them, let's have withdrawal bleed. Again, I will try with OC pills or come for LNG IUS. And what to do? If they are having severe hypoestrogenic side effects, they are not having any ovarian endometrioma or a deep infiltrating endometriosis, you have to go on trying the medical management only.
Yes. So that clarifies a lot of our doubts. And any more questions? Would anybody like to ask Madam any question, or we can move to the second session now?
I have one point to make, Monica, if I'm allowed.
Yes,
Am
please.
I allowed?
Yeah, sure.
Yes, please.
So, Elagolix, what I reserve is for severe pain. If patient is not responding to NSAIDs or other, and it has not, to OCP and all, is not able to reduce pain, I do use Elagolix, and it has fantastic results in decreasing the pain. But as you said, right, left, center, we should not use it. So there is an indication, and it has a fantastic pain relief. Plus, as Dr. Lakshmi said, that once you stop it's reversible quickly. Whereas GnRH analogs, they have around 6 weeks effect when we give the injectable. Yeah. So I think Elagolix has its advantage, but as you said that only people who know about endometriosis, like gynecologists or IVF specialists, they should prescribe these medicines.
But here in India, everything falls in the hands of GPs, and I really don't know whether it is a OTC drug or whatever, how they are prescribing and how patients are getting. I mean, we don't have any control. We can only teach and make our fraternity aware that this is a second line drug. It's a very good drug. I mean, very effective drug, but we should use it judiciously after counseling our patients thoroughly about the pros and cons of that drug. And of course, monitoring and follow-up also makes a lot of difference.
Thank you, Lakshmi ma'am, for the extensive explanation, and for the benefit of all those who are watching. This lecture, Madam's talk, and the rest of the sessions can be watched on YouTube via the YouTube link of our channel. They will be permanently recorded, and it's free for everyone to log in and watch. Thank you so much, Lakshmi ma'am.
Thank you. Thank you.
We would love to have you again and again in the program, because you are an encyclopedia of gynecology, ART, obstetrics. So how do you manage all the three fields, and how much your brain can accumulate, madam? It is a surprise to all of us. So thank you so much, Lakshmi ma'am. Thank you.
Thank you, dear.
Dr. Virul, you can start session 2 now.
Thank you, ma'am. It was a great session. Now we are proceeding towards our next session, which is on the topic endometriosis and infertility. Vishal sir. It's an honor to introduce our chairperson. First, we have Dr. Raj Lakshmi ma'am. She's the president at Manipal Obstetric Society. Welcome you, ma'am. Next, we have Dr. Veena S. Bhatt ma'am. Ma'am is president at Shiva Moga Obstetric Society. Welcome you, ma'am. Next, we have Dr. Viresh Nagatan sir. Sir is president at Bagalkot Obstetric Society. We welcome you, sir. Next, we have Dr. Madhu K. sir. Sir is president at Davanagari Obstetric Society. Welcome you, sir. Next, we have Dr. Sapna Kali ma'am. Ma'am is president at Gadag Obstetric Society. Welcome you, ma'am. Next, we have Dr. Prakash Virandur sir. Sir is president at Hubli Dharwad Obstetric Society. We welcome you, sir. Next, we have Dr. Vaishali Pandit ma'am. Ma'am is president at Haveri Obstetric Society. Welcome you, ma'am. Next, we have Dr. Pradeep Basal sir. Sir is secretary at Haveri Obstetric Society. Welcome you, sir. Next, we have Dr. Pooja Patil ma'am. Ma'am is Secretary at Hubli Dharwad Observing Society. Welcome you, ma'am. Next, we have Dr. Shilpa Daroti, ma'am. Ma'am is Secretary at Gadag Observing Society. Welcome you, ma'am. Next, we have Dr. N.R. Divakar, sir. Sir is Secretary at Davanagari Observing Society. Welcome you, sir. Next, we have Dr. Rajeshwari Patil, ma'am. Ma'am is Secretary at Belgavi Observing Society. We welcome you, ma'am. Next, we have Dr. Manohar Sankasali, sir. Sir is Secretary at Bagalkot Observing Society. Welcome you, sir. Next, we have Dr. Swati Kishore, ma'am. Ma'am is Secretary at Shivmoga Observing Society. Welcome you, ma'am. Next, we have Dr. Indra Pai Shabang, ma'am. Ma'am is Secretary at Manipal Observing Society. Welcome you, ma'am. Next, we have Dr. Ramya N.R., ma'am. Ma'am is Secretary at Mangalore Observing Society. Welcome you, ma'am. Now, I request our chairperson to introduce our speaker, Dr. Monica Singh, ma'am. I request Dr. Veena, ma'am, to introduce Dr. Monica, ma'am, our next speaker.
Yes. Namaste. Good evening at all. Can you hear me, ma'am?
Yes, madam.
Yes, ma'am.
Thank you so much.
Good evening to all. Really, it's an honor for me to introduce Dr. Monica, and she's such an as Dr. Sonia Mandappa told rightly, synergy means energy. So Monica Singh means energy. Is such a vibrant character, and the way she is channelizing all these academic sessions, it's very good, ma'am. And to introduce, I'm very happy. Dr. Monica Singh, she is a consultant reproductive medicine and endoscopist, Bhopal Fertility Endoscopy Maternity Center, and she is the professor and Department of Obstetric Gynecology, Ellen Medical College, Bhopal. She is President-elect Bhopal OB/GYN Society and Founder-President, ISOPAR Chapter of Bhopal 2024 to 27, and National EC Member for ISAR, and Vice President Bhopal Menopause Society, Honorary Secretary, and MP Chapter ISAR, Joint Secretary cum Joint Treasurer MP IAGE, Coordinator Foxy Infertility Committee, Founder Secretary MP Chapter IFS, and past Joint Secretary and Secretary Vice President Bhopal OB/GYN Society, past Committee Member Foxy MDA IP Sexual, and she has got lots of laurels. Academic, she has won more than 10 gold medals and presented more than 50 original international research papers, and this over 500 talks she has given in national conferences. Contributed 8 book chapters as a first author. Contributed chapter 2 Foxy Focus, 2 ISR Express. Oh, so I think awards are so many. She is actually Pillar of Strength Award in November 2024, Star of Delhi ISR 2023, Woman Entrepreneur Award, Vivekananda Library Bhopal Achievement Awards, Woman Achiever Award, Lions Club Bhopal. And so she has got such an organization and extracurricular skill. She has organized many conferences as a chairperson and organizing secretary, National ISR Embryology. She has got her own website, and she is at present she is convening this webinar series, Synergy. So all of you know, I'm very happy to introduce Monica Singh, and today we have got endometriosis topic. It is very much indeed essential for all of us. Thank you so much, madam. Very nice to introduce.
Madam, this is the first time somebody has introduced me in so much detail, madam. Thank you so much, ma'am. Thank
Deserve
you.
more than that, ma'am. Thank you.
I don't deserve even 1% of it, madam. I'm a very, very small person, madam. Please. You are all senior to me, and I'm indebted to you for your love and affection.
Thank you, ma'am.
Thank you so much. My topic is today the infertility aspect of endometriosis. From here, after Lakshmi Madam's talk, let us start the next part of synergy. Though we would have started with the surgical management, but Dr. Krishna Kumar sir would be joining a little later. So I thought let us consider the infertility related problems of endometriosis. What are the considerations and treatment options as far as the current guidelines are concerned? The overview of my talk will take you through the disease and the fertility impact, how endometriosis actually damages the ovarian tissue and reduces ovarian reserve. Number 2, what are the medical and surgical options pertaining to endometriosis with their benefits, limitations, and risk of each treatment approach? Number 3, ART outcomes. When we do IUI or IVF, how do we select the therapy and what are the results and outcomes across the stages of endometriosis? The stages we will consider are according to the ASRM classifications and special considerations of conditions like risk of malignancy. What happens when a patient with endometriosis conceives? What are the pregnancy complications? And is there any risk of infection during the IVF procedure? We all know that endometriosis is a chronic inflammatory disease causing pain and infertility. Lakshmi Madam has extensively dealt with what a great gap and latency is there in the diagnosis in women of reproductive age group. Roughly, the stats say that 25 to 50% of infertile women have got endometriosis. And about the same percentage, 30 to 50% of women with endometriosis are infertile. So this is an important data. And how does endometriosis actually cause infertility? So this is very simple, but it's important for us to understand when we counsel the patient. Lakshmi Madam stressed that your patient goes away to another gynec or to a surgeon or to a GP or to a Baba because she feels the doctor is not curing my disease. You have to explain her the derangement starts from immunological derangements. You have got, this patient has got altered immune, endocrine, paracrine, biochemical environment, which is actually reducing the oocyte gamete quality, as well as it will also affect the embryo quality. She will have progression of disease, which will lead to pelvic adhesions. The pelvic adhesions not only cause a distorted anatomy, but they may also ultimately lead to bilateral tubal blockage, which impedes fertilization and gamete transfer. Then we have endometrial dysfunction. There is progesterone resistance and altered receptivity markers, which contribute to subfertility. Just give me a minute, please. I'll take a call. Hello? Sir, your talk will start at 7:15, sir. Your talk will start at 7:15, sir. Sir, we will send the link to you. We will send the link. Yes, sir. Dr. Purva, please forward the link to Krishna Kumar, sir.
Yes, ma'am.
Yeah, thank you. So we have got endometrial dysfunction in the form of progesterone resistance and altered receptivity markers, which all contribute to subfertility. Now, what is the effect of endometriosis on the very important structure of the female reproductive tract, that is the ovary? How does it affect ovarian function? The mechanisms of ovarian tissue damage are twofold. First of all, there is an inflammatory reaction by increased number of damage-causing immune cells, elevated levels of cytokines, chemokines, and reactive oxygen species. And all these cause inflammation, and the result of that inflammation is healing and fibrosis, tissue fibrosis. Then the sheer growth of the endometriotic cyst and the endometriotic patches and the implants causes mechanical damage. There is compression of ovarian tissue, there is stretching of ovarian tissue, even the deposits on the mesosalpinx, the paraovarian tissue, the sacrococcygeal area, the POD, everything damages the ovarian tissue at the end of the day. It also leads to hampered blood circulation, and the vessels which are formed have got disturbed neovascularization. They are haphazard. So this is how the ovary gets progressively damaged. There is also inflammatory damage to the follicles. Now, this endometriotic cyst or the chocolate cyst fluid contains very high concentrations of toxic substances, including the reactive oxygen species, inflammatory molecules, proteolytic enzymes, and free iron. Since primordial follicles lack their own vascular network, they are totally dependent on the healthy cortex-specific vascular stroma for their blood supply as well as for early follicular development. So when endometriosis will disrupt the cortical blood supply, it will also cause disruption of the follicular development. The reactive oxygen species also induce oocyte apoptosis and necrosis of the early developing follicles, thereby driving it towards tissue fibrosis and progressive follicular atresia and follicular depletion. Now we come to a very important procedure of oxidative stress damage, that is the Fenton reaction. So endometriomas contain a very high concentration of free iron. So this has been analyzed as compared to other body fluids, serum, blood, and other benign ovarian cysts. The endometriotic fluid contains free iron that mediates the ROS production via something called a Fenton reaction. This is nothing but the reaction between free iron and the H2O2, hydrogen peroxide. So these two compounds, one element, free element, and H2O2 molecule, they react with each other. And what do they produce? They produce hydroxyl ion. So the hydroxyl ion is the key factor which damages the ovarian cortex. And this causes a sort of, inflammation, severe inflammation in the cortical tissue. Along with transforming growth factor beta, this drives chronic fibrosis and decline in the oocyte number and quality. And this Fenton reaction is actually used in the wastewater management and in treating the toxins of the ground. So the Fenton reaction is used to kill the most toxic substances in the wastewater treatment. So can you imagine what havoc and damage it is causing inside the body in the ovary? So endometriosis is ultimately going to reduce the ovarian reserve. The antral follicle count is significantly lower in ovaries with unoperated endometriomas vis-a-vis the contralateral healthy ovaries. Even in the same patient, if you've got a unilateral endometrioma, you will find the AFC. This we see day in and day out. We put a TVS probe. It is very difficult to assess and count the antral follicles of the ovary having the endometriotic cyst. Similarly, when we assess the serum AMH, this is significantly lower in severe, moderate to severe cases of endometriosis. ASRM stage 3 and 4 will show a lower serum AMH as compared to other cysts like mature cystic teratomas or pseudomucinous adenomas. Severity also matters. Moderate to severe endometriosis will show significantly lower AMH as compared to minimal to mild cases. What is scary is that there is progressive and steep decline in the ovarian reserve. Endometriosis patients show a faster decline in serum AMH than in healthy controls, even when you consider two poor responders, one having endometriosis and another poor responder due to any other cause. The endometriosis patient will show a faster decline and depletion of the ovarian reserve. And this is shown in the graph. With age, there is a reduced reserve and a steep decline. And these women are also likely to experience menopause earlier. So these are the key statistics related to endometriosis and infertility. Women under 35 years with endometriosis are 2 times more likely to experience infertility as compared to the 15 to 20% monthly fecundity of healthy women. The fecundity of endometriosis patients is only 2 to 10%. So what is fecundity? It is the potential to reproduce. The fertility means your actual number of offsprings which are born to a particular woman, and her fecundity is her biological potential, maximum what is the reproducing capacity. So that fecundity is markedly lower in endometriosis patients. Having said that, if you do not intervene, 50% of women with mild endometriosis can still conceive with a wait and watch, or when she just, progresses in her reproductive career. But moderate types of endometriosis, only 1/4 of the patients will be able to conceive without intervention, and they will have disease progression. So medical treatment options have been dealt with beautifully by Lakshmi Madam. I want to stress that medical therapy, whether it's a neoadjuvant therapy or is its adjuvant to surgery or a precursor to surgery, has got no real definite beneficial effect on infertility treatment or on improving live birth rate. The options available to us are oral contraceptives, progestins, aromatase inhibitors, GnRH agonists, and now oral antagonists also. So all these agents will primarily inhibit the ovarian function, provoking contraception or subfertility, which is actually against the aim we have of treatment. So coming to this very simple table of comparing the advantages and disadvantages of the medical vis-a-vis the surgical treatment, definitely the medical treatment is having the advantage of no surgery, no risk of anesthesia, no ovarian reserve decline, no delay in recovery. But the disadvantage is that you are causing inadvertent contraception, you are making the symptoms persist, you're allowing the disease to progress. The cyst which is there in the body can undergo complications, it can grow, it can rupture, it can undergo torsion, and there is no histological diagnosis available to us. Though it doesn't matter, Madam also said histological diagnosis is not necessary, but the medical treatment might delay the actual aim which you want to achieve as far as fertility is concerned. Coming to surgical treatment, there is symptomatic relief, of course. You also get tissue for histology. The risk as related to the cyst complications is reduced, but the surgical complications are there, anesthesia complications are there. Some of these surgeries of DIE can go into hours, which Dr. Krishna Kumar sir will be detailing shortly. There is profound decline in the ovarian reserve. There is possibility of post-operative adhesions, recurrence, and a possible treatment delay. So the surgical treatment options have gone from laparotomy to laparoscopy to now robotic surgery. The open surgical approach is very rarely used unless it's a very complex case or you totally cannot deal with laparoscopy. The gynec surgeon might resort to this. But laparoscopy is the most widely accepted method. More and more gynecologists are getting trained and updating their skills and learning to use the laparoscopy, operative laparoscopy easily and effectively. And whenever you put in a scope, you should be, with the aim to operate and with the aim to do the best surgery. So the laparoscopic surgery approach has got a shorter recovery time. As time is going on, you're having lower cost of laparoscopies, and it is definitely preferred for diagnosis and resection, whatever procedure you want to do. Robotic surgery is an emerging minimally invasive option. The advantage is dexterity, precision, but the disadvantage is the increased cost, the equipment. You should have the facility. And I really don't know, the robotic surgeons would be able to tell us how it really helps in a DIE or in advanced cases of endometriosis. Routine surgical treatment is generally not recommended for early stage cysts without specific indications. The core concern about surgery is the effect on the ovarian reserve, and this is because the traditional teaching was to enucleate the endometriotic cyst. Here we are dealing specifically with the endometrioma. The stripping technique was used for teasing out the endometriotic cyst, but inadvertently, this removes the normal ovarian tissue. Because the capsule around the endometriotic cyst is actually a compressed cortical tissue, a pseudocapsule, and in almost more than half of the endometrioma resection, the ovarian tissue is also removed out or, sort of stripped out, and this can cause a gross reduction in the ovarian reserve. So this has gone into disrepute, laparoscopic stripping or cystectomy. So the AMH decline after surgery, another question which so many postgraduates and juniors ask is there AMH decline after surgery? The patient is also concerned. So these are the statistics for you from the latest guidelines. The overall AMH decrease post-operatively after an endometrioma surgery is about 38%. When you do a unilateral cystectomy, the AMH reduction can be to the tune of 25 to 30%. With a bilateral procedure, it can go up to 45%. And the mechanism of surgical ovarian damage is as follows. You have got not only the follicular loss directly You also cause thermal damage if you use, a lot of energy. You lead to vascular injury directly by your instrument or by the energy source, and this can lead to long-term ischemia. The short-term damage to the ovary is within a week, and it is driven by inflammation, edema, ischemia. The long-term progressive decline is attributed to impaired neovascularization. So the surgery and fertility outcomes can be divided into ASRM stages 1 and 2, which are minimal mild endometriosis, and ASRM stages 3 and 4, which are moderate to severe endometriosis. In minimal mild endometriosis, laparoscopic excision or ablation improves the spontaneous pregnancy and live birth rates vis-a-vis expectant management. Similarly, in the severe stages, surgery treats pelvic adhesions, and cumulative pregnancy rates 3 years post-surgery can be significantly higher than expected management. Having said that, there is a procedure where, the decline of ovarian reserve is minimum. That is drainage, ablation, or simple draining the cyst, but this will also lead to faster recurrence. And another word of caution, whenever the primary surgery is done for endometriosis, that should be the best surgery and should be done by the expert, not by beginners, not by trainees, because the patient will have a better chance as far as the fertility outcome is concerned. The surgeon should always try to minimize thermal damage. Even when we use bipolar cauterization for hemostasis, it damages ovarian reserve much more than using fine sutures or using hemostatic sealants. Surgeons should minimize this damage by clearly exposing the dissected tissue, avoid blind coagulation, and exercise caution when operating near the ovarian hilum where the blood vessels are bunched together. The tissue-sparing surgical techniques have also been described in the current literature. One is the Donnet combined technique by a French surgeon, where there is conventional cystectomy they do for the distal portion of the endometriotic cyst, but the remaining tissue, 20% of the cyst near the ovarian hilus, they use a CO2 laser. But no proven benefit has been seen on ovarian volume or AFC as such. Similarly, comparing coagulation with cystectomy definitely, the conventional cystectomy, which we were trained to do, has got better pain relief, lower recurrence, but it leads to faster decline of ovarian reserve. Coagulation will cause less decline of AFC and volume decrease in 6 months, but will have more chances of recurrence. So another multi-surgical or 3-step surgical technique, which is now described in literature, is that you simply do a drainage and take tissue for biopsy at the first primary surgery, then put the patient on 3 months GnRH agonist therapy. After that, either you do your ART procedure or do a second look laparoscopy. You can do ART procedure after the drainage and biopsy also. So this randomized control trial, sorry, I could not put the year, it is 2019, has been proposed by Soulakidis and his group. After 6 months, AMH was significantly reduced in the cystectomy group, but not so significantly in this 3-step surgery group. And AFC was also found to be significantly higher when you use the 3-step approach. What about recurrence after surgery? Endometrioma is notorious for recurring, and there's a 36% probability of a second-line surgery due to recurrence as early as 2 to 5 years post-operatively after doing a primary laparoscopic excision. The multi-step procedure, which was described in the previous slide, may reduce normal tissue removal and thermal damage, but its effect on recurrence is unclear. Coming to ART, the favorite and the simplest procedure for mild to moderate, minimal to mild cases of endometriosis is IUI, which is a simple first-line option for couples who have got normal semen parameters. Here, always try to put the patient on controlled ovarian stimulation. You can use your combination of CC, letrozole, and or gonadotropins plus IUI to have the best results. Now, it has been found when you do a surgery, a well-planned surgery before IUI, the clinical pregnancy rates of IUI might be better. And in moderate to severe cases of endometriosis, IUI is typically not attempted or advised due to pelvic adhesions, decreased tubal function, and very low pregnancy rates. So these patients are fast tracked towards IVF. So comparing the IUI pregnancy rates in infertile patients, these patients of mild to minimal to mild endometriosis display a lower pregnancy rate after COS IUI than women with unexplained infertility. But remember, when these patients undergo surgery, so there are 3 bars over here. The maximum pregnancy rate is with unexplained infertility, IUI is being done, the classical cases. With endometriosis, where a prior surgery has been done, you get a better pregnancy rate. But with mild to minimal endometriosis, where no prior intervention has been done, the pregnancy rates are just half of the second group. Coming to IVF, what is the ovarian response in cases of unilateral endometrioma and you are doing IVF? Definitely, there is reduced responsiveness. Women with unilateral ovarian chocolate cyst show a reduced ovarian responsiveness during controlled stimulation, which is directly proportional to the endometriotic cyst size, location, and number. And other retrospective analysis, other studies have found no such significant difference in the antral follicles or total oocyte retrieved in women having unilateral endometrioma. So there's a contradiction there. What do you do when your patient wants to progress to go towards IVF without surgery? She just wants an IVF, or you want to do an IVF and you want to avoid surgery. So this is what meta-analysis says, that women with endometriomas undergoing IVF without a prior surgical management had similar clinical pregnancy rates and live birth rates as like those without the disease, though the mean oocytes retrieved in these patients were lower and cycle cancellation rates were significantly higher. So basically,
Connection probably lost, ma'am.
Hello.
Madam, I think Dr. Monica, madam, connection is got lost.
Yes, yes.
so sorry, there is some bad weather in Bhopal. My Wi-Fi went, so now I am on data. I will start sharing again. I'm so sorry for the interruption. Can you see my slides now? Hello, Purva?
No, ma'am, not yet.
Hello.
No, ma'am, we are not able to see your slides, ma'am.
Okay, I'll share again. Are they visible? Hello?
नहीं मैम अभी नहीं.
Not yet, not yet.
Sure. So,
Ma'am, I'll
No,
recommend that
ma'am,
you
it's
are, ma'am, your bandwidth is low, so kindly turn off your video and then try to share, ma'am.
okay, I'll do that. We are on a generator right now, so yes. I'll turn off my
ma'am,
video.
if there is problem, you can send the PPT to me. I'll just play it.
Yeah, I'll just try once, Purva.
Okay.
It's visible now, ma'am.
It's visible? Okay, fine,
Yes.
fine. Okay, so we have got, we were on the, yeah. So we are not going to do surgery before IVF. And surgery before IVF, what does evidence say? Evidence says that when you operate on an ovarian endometrioma less than 3 centimeter prior to ART, there is no evidence of improvement in the outcome. And some case studies also show no detrimental impact of excision on IVF ovarian response. So again, there is a lot of contraindication, but definitely there is one thing which is definite, that in cases of DIE, this effectiveness of surgical excision is not conclusive and not advised. It is not going to improve your results, but this area is again under research. So you should remember, when it is an ovarian endometrioma, the size is small and you can easily approach your follicles for retrieval. It is better not to operate before your IVF. Again, what about second line surgery? Many of these patients come to us with a previous laparoscopy. They have again got an endometrioma, they have got disease recurrence, and they ask for a repeat surgery. Here you have to tread very cautiously. The probability of pregnancy, according to evidence, repeats after repeat surgery for recurrent endometriosis is lower than after primary surgery. And the number of oocytes retrieved, the number of mature oocytes and high-grade embryos will be significantly lower in the second line surgery group. So even if endometriosis recurs, second line conservative surgery should be really taken with a pinch of salt and carefully considered with caution and with counseling in a woman who is wishing to conceive. What about IVF outcomes, surgery versus no surgery? Systematic reviews have said they have got similar clinical pregnancy rates, live birth rates, and mean oocytes retrieved between these two groups, whether they are going for IVF with untreated endometriomas vis-a-vis those who underwent excision prior to IVF. So this is totally reverse of IUI. In IUI, they are saying a prior surgery and then doing an IUI with controlled ovarian stimulation will give you better pregnancy rates. In IVF, surgery has got no advantage as such. So this is the decision for infertile women with endometriosis. You can see infertile women with suspected endometriosis, you do a workup, you do your ovarian reserve testing, you stage the disease into minimal, mild, or moderate severe. Where it is minimal, mild with no male factor, patent tubes, you can go for surgical treatment, which is COS IUI done very well for 3 to 6 cycles. If it doesn't work out, you go for IVF-ICSI. For moderate to severe endometriosis, you have to consider patient-specific individualized decision-making, and either you go for IVF-ICSI directly. In selected cases, you can go for COS IUI. I have at least half a dozen cases of moderate to severe endometriosis conceived with IUI, so you cannot abandon that treatment completely. So coming to the summary of the algorithm, number 1 is the infertility workup. You do your completely history, labs, and imaging. Second, you do the ovarian reserve testing, AMH and AFC, to assess the ovarian reserve. You stage the disease, classify it as minimal, mild, or moderate severe, and then you select the treatment, whether you want to progress to COS IUI or proceed to IVF-ICSI. Actually, the segregation is very simple. Minimal, mild, and moderate severe, just stage the disease and individualize the patient, categorize her into the particular categories. Having said that, if she's already a patient with poor ovarian reserve, advanced age, or other indications of IVF like a male factor, directly this patient can go straight away to IVF-ICSI, bypassing the surgical staging. So this is the treatment by endometriosis stage, which is summarized. Minimal, mild ASRM stage 1 to 2. You do a surgery. You do COS IUI 3 to 6 cycles. The outcomes are comparable to unexplained infertility. This is kept as a baseline standard. In ASRM stages 3 to 4, the decision has to be patient-specific, multidisciplinary, and decision-making should be done. Surgery may reduce ovarian reserve and adversely affect the IVF results. So ASHRAE recommends that surgical excision is not routinely to be done before ART, and better it is to progress directly towards IVF and ICSI. Many postgraduates and many practitioners question, should you measure AMH before surgery and when should you measure it after surgery? So clinicians should assess the ovarian reserve before deciding whether to surgically remove the endometriotic lesions. This baseline value should be there. And then it is recommended to measure the AMH, at least give 3 months post-operatively in order to determine an optimal treatment plan. The criteria for specific AMH threshold values for formulating your decision is not established. Like the guidelines do not tell us if post-operatively your AMH is 1.5 what to do, 2.5 what to do, 0.5 what to do. So that decision you have to make according to your individual patient. What are the other considerations during treatment? Number one is a very rare complication. The 5-year cancer risk is not in women of endometriosis who undergo ART. However, multiple studies have documented a slight association between ovarian endometrioma, the tissue, and ovarian cancer of clear cell type and endometrioid histology. So even if this probability of malignancy is low, clinicians, first of all, we should consider the possibility that an endometrioma may progress to cancer. Medico-legally, should we share it with the patient? I really don't know. I would like to ask Lakshmi Madam once this talk is over. So what happens to the pregnancy and what are the complications associated with the pregnancy with endometriosis patients who become pregnant? Number one, these patients have got a delayed implantation, so they will have placental issues like low-lying placenta, placenta previa, placental insufficiency, FGR, more chances of PIH and obstetric hemorrhages. Pregnancy losses may occur because of the implantation beyond the normal window of implantation, leading to spontaneous abortions and RPS. These also patients suffer from a premature decidual senescence, leading to premature deliveries and SGA babies. There is no evidence that surgery for endometriosis can prevent the negative effects of endometriosis on your pregnancy outcomes. Does the disease progress during IVF cycles? Now, endometriosis is an estrogen-dependent condition, so there are concerns whether a patient undergoing COS can have disease progression. However, when we studied these patients, the studies have found the cumulative recurrence rate with patients undergoing ART is similar to controls, and gonadotropin treatment does not actually affect the natural history of the progress of endometriotic lesions, and the temporary high estrogen exposure that occurs during IVF is not a risk factor for endometriosis recurrence. This we have to reassure ourselves as well as the patient. So endometriosis during surgery, and specifically a chocolate cyst during pregnancy, not during surgery, during pregnancy, how does it behave? You'll be surprised to know that almost 50% of the cases, the cyst size decreases during pregnancy. In about 30% of cases, it remains unchanged. In about 20% of the cases, the cyst size increases and the lesion may show a particular type of decidualization because of pregnancy, abscess formation, or even rupture. So most of the lesions, we can be reassured, do not change significantly, and you can watch or conservatively observe during pregnancy. And gynecologists who are doing their obstetric scans should always keep in mind the first and the second trimester, you can watch the ovaries very nicely. In your obstetric scans, you can go to the adnexa, see the morphology of the ovary, and check whether the ovaries are normal and the patient is not symptomatic. Now, another concern about IVF specialists is when they do an oocyte retrieval with endometrioma or multiple endometriomas. Now, these endometriotic cysts contain metalloproteinases, cytokines, free iron, and ROS. All are potentially toxic to oocytes, and when inadvertently you puncture them with a oocyte retrieval needle, you will aspirate that brownish fluid. Sometimes it contaminates the follicular fluid, but you can, wash those oocytes multiple times and use in the laboratory for IVF ICSI. There is no evidence as such that these oocytes go waste. And what happens to the endometrioma if there is inadvertent puncture? You should not be scared that an abscess will form outrightly. There are very rare cases where a puncture of endometrioma has led to abscess formation. More likely than not, you can, just wait and watch, put that patient on antibiotics after the procedure. You can even keep on oral antibiotics. I put the patient on oral antibiotic, something like, amoxicillin, clavulanic acid for 5 to 7 days, and, have a good outcome. Though this endometriotic fluid does act as a culture media for pathogens, but abscess does not form that easily. So, coming to the end of the talk, conclusions and key takeaways. Endometriosis is basically affecting the ovarian reserve, and this ovarian reserve has got a dual threat. It is reduced not only by the disease itself, but also when you do a surgery for it. There is correlation between severity and disease progression. The severity of endometriosis is directly related to the degree of ovarian reserve reduction and probability of pregnancy. And without treatment, endometriosis causes a faster AMH decline than happens in natural aging, and these women also have an earlier menopause. Medical treatment has got little effect on fertility treatment. The surgical treatment, bottom line, we had already discussed. What is best for minimal to mild endometriosis is surgery followed by 3 to 6 cycles of COS IUI. Moderate to severe endometriosis, ESHRE guidelines do not routinely recommend surgical treatment before ART. IUI remains the first line for minimal to mild cases, and second line surgery to be discouraged. And even if you do it, proceed with great caution in women who are wishing to conceive. Personalized, individualized care is essential. Physicians should accurately diagnose patients' conditions and provide personalized treatment plans, taking into account the advantages and disadvantages of each treatment option that they offer. Ovarian reserve assessment is crucial, and you can do a pre-operative AMH, a post-operative AMH, and together, along with the patient criteria, you can have an individual plan, and there are no specific threshold of AMH as such in the guidelines. So this is a summary of everything I've talked about related to ovarian cancer, pregnancy complications, disease progression, related to COS, follicular contamination when it happens, and possibility of post-oocyte retrieval infection. What are the research areas where things can develop? First of all, this multi-step or three-step procedure requires research. DIE requires research. We'll be listening in the next talk how to operate on DIE and whether it's worth it. AMH threshold values, whether there should be any sliding scale for AMH threshold values in endometriosis. And of course, can you do surgery for moderate to severe cases of endometriosis before IVF? So you should be well versed with your ASRM classification to stage the disease. The visual algorithm should be in your head. Again, the key figures at a glance, that the cumulative pregnancy rates you should know, and the AMH decline after cystectomy we should all be aware. These are my references. And the last slide, but not the least, the management of infertility due to endometriosis is a challenge. The key is to consider your goals, your patient's fertility goals, ovarian reserve, and disease severity at the center of every decision you make. You have to assess the ovarian reserve before and after the intervention, individualize your treatment based on the stage, the patient, her ovarian reserve, her patient goals, and collaborate in a multidisciplinary fashion with shared decision-making with the patient or the couple. Humbly seeking your blessings for my candidature as chairperson, FOXI Infertility Committee, in the forthcoming FOXI elections, where voting will be done from 15th to 25th of August. Thank you very much.
Hello, Dr. Krishna Kumar.
Good evening. Good
Yeah,
evening,
good evening, good
ma'am.
evening.
Welcome, Kamini ma'am. So nice to see you. Good evening, Krishna Kumar sir.
Yeah.
Good evening. Good evening. Yes, thank you for inviting me.
Sir, we are very eager to listen to you, sir, but we have the pleasant duty of introducing our chief guest before you start your talk.
Sure.
Padma Shri Dr. Kamini Rao ma'am is with us. So, Vishal, can you please share Madam's CV? Dear friends and respected seniors and colleagues, let's put our hands together to welcome the past president of ISAR and past president of FOXI, Padma Shri Dr. Kamini Rao ma'am. Ma'am, we are honored to have you in our midst and your blessings. Madam is the co-founder and chairperson of Medline Academics, the co-founder and chairman of Dr. Kamini Rao Group of Hospitals. She is a Padma Shri, which was awarded in 2014 in recognition of her distinguished service in the field of reproductive medicine. Madam has got the Karnataka State Rajyotsav Award for invaluable service in the field of medicine in 1997. She's been honored with Karnataka Vaidya Ratna Award in 2021, Lifetime Achievement Award by K. Kasoga in December 21, Kempe Gowda Award for Outstanding Services and Achievement in the Field of Medicine in 2018, Kengal Hanumantia Award in 2018, BC Roy District Award from Shimoga District Unit of IMA, Lifetime Achievement Award for IVF and Infertility Care from Times Health Excellence in 2018, Lifetime Achievement Awards and Honors for Dedicated Service, Contribution Achievements in the Field of OBGYN in 2012, Honorary Fellowship of the International Academy of Human Reproduction, Honorary Doctorate for Doctorate of Science at 54th Annual Convocation of Bangalore University, Lifetime Achievement Award from ISAR, Lifetime Achievement Award from FOXI, honored with Vidya Vibhushan Award in 21 by ICOG, Distinguished NBE Teacher Award by Association of National Board of Accredited Institutions, India's representative to FIGO, and the first lady representative from India, and the first person from Karnataka to be so, FIGO Award in recognition of women's gynecologists and obstetricians in Rome in 2012. Madam has published the books, author of the Infertility Manual 4th edition, editor of Principles and Practice of Assisted Reproductive Technology 3rd edition, and published over 52 textbooks. Madam, we are so blessed to have you amongst us. And ma'am, we would love to have words of blessings from you.
Thank you very much for inviting me to be the chief guest here. And I believe that today I stand before you or between you and all the lovely lectures that are going to follow. I'm sure Krishna Kumar is waiting to give his lovely talk. But endometriosis as a disease is still an enigma. Because whether we talk about endometriosis in the extra spaces or extra uterine, or whether we are talking of adenomyosis, the etiology remains different and it still is an enigma. While trying to understand and treat, I don't know in the whole process whether you try to convince or confuse the audience, because you go back with more questions rather than answers, because it is a disease that works like cancer, is not cancer, and it is such a frustrating phenomena that you can't tell the woman that you are perfectly cured of endometriosis and therefore you can conceive and everything should be fine. So with these few words, I would like to say to all the members in the audience that webinars are a way of disseminating knowledge, and I'm sure that this webinar has a star galaxy of people who are going to talk on different aspects of endometriosis management, and I'm sure it's going to be a wonderful bonanza of knowledge sharing. And thank you, Monica, for inviting me for this program, and I wish this seminar all success. Thank you very much.
Thank you. Thank you so much, Kamini ma'am. It really means a lot. You could take out time from your busy schedule and join us, madam.
Thank you.
Really, Synergy and myself, we are really obliged to you for your kindness, ma'am. Thank you so much.
Thank you. Thank you.
I now request Dr. Purva Bhatkur to start session 3, and Dr. S. Krishna Kumar sir is amongst us. So let us start the session 3, which I know audience is very eager to know about the surgical management of endometriosis. Welcome, sir.
So moving to our third session, that is surgical management of endometriosis. We welcome chairpersons. Dr. Purnima Manu Prasad, Madam. Madam is presently Secretary of Hassan OBGY Society. We welcome you, ma'am. We have with us Dr. Gitanjali G. Madam. Madam is presently Secretary of Chikamangaluru OBGY Society. We welcome you, ma'am. We have with us Dr. Tanuja Obli, Madam. Madam is presently Secretary of Vijayanagar OBGY Society. We welcome you, ma'am. We have with us Dr. Mamta Loli, Madam. Madam is presently Secretary of Vijayapura OBGY Society. We welcome you, ma'am. We have with us Dr. Raju V. Giradi, sir. Sir is presently Secretary of Raichur OBGY Society. Welcome you, sir. We have with us Dr. Madhura Banale, Madam. Madam is presently Secretary of Gulbarga OBGY Society. Welcome you, ma'am. We have with us Dr. Savita Badigare, Madam. Madam is presently Secretary of Bidar OBGY Society. We welcome you, ma'am. We have with us Dr. Priyanka Parvati, Madam. Madam is presently Secretary of Basaval Kalyan OBGY Society. We welcome you, ma'am. We have with us Dr. B.K. Anupama Sundar, Madam. Madam is presently consultant at Ballari OBGY Society. We welcome you, ma'am. We have with us Dr. Jeevan Reddy, sir. Sir is presently Secretary of Tumkur OBGY Society. We welcome you, sir. We have with us Dr. Sindhu Lakshmi D. Madam. Madam is presently Secretary of Mysore OBGY Society. We welcome you, ma'am. Next, we have Dr. Shilpa M.N. Madam. Madam is presently Secretary of Mandya OBGY Society. We welcome you, ma'am. We have with us Dr. Soumya S. Madam. Madam is presently Secretary of Chitra Durga OBGY Society. We welcome you, ma'am. We have with us Dr. Shushma S. Madam. Madam is presently Secretary of Chikabalapura OBGY Society. We welcome you, ma'am. Next, we have with us Dr. Vijay Kumar C.R. Sir. Sir is presently Secretary of Bangalore OBGY Society. Welcome you, sir. Now I hand over the session to our chairperson to introduce our speaker, Dr. S. Krishna Kumar, sir.
Can I start? Can I share?
Dr. Gitanjali, Madam is there. Sir, just Dr. Gitanjali. Yes, ma'am. Monica,
Madam is
ma'am.
introducing, sir. Yeah. I will do the honors.
Yes,
I'm
ma'am.
very privileged. We are very privileged to invite amongst us Dr. S. Krishnakumar, sir. Sir is the Chief Consultant at JK Women's Hospital, Fortis Hospital, Mumbai, Course Director of the Cadaver Course and AAGL IAGE CSEE MIG course, past President of IAGE, ASHRAE Certified Reproductive Endoscopic Surgeon. His center is recognized for ICOG Fellowship 6 months ART and endoscopic surgery. Sir is the recipient of the National IMA Award 2019-20, Eminent Medical Man for Distinguished Achievement of Highest Order. We welcome you, sir, and we would love to hear your deliberation on surgical aspects of endometriosis.
Thank you for inviting me, Dr. Monica Singh. And of course, I must thank the Synergy team and the Kasoga Society for having me in this webinar, where I am going to be talking on the surgical management of endometriosis. As just now Dr. Kamini Rao mentioned to us, it's still an enigma and we keep on changing our theory. Now, but what is the hottest topic today in gynecology is robotics and endometriosis. We know the types of endometriosis. 25 years back, we used to get such simple endometriosis, more peritoneal. The other variety is endometrioma, but today deep endometriosis is increasing on the rise. Now, what we were told, as Dr. Monica already said, stage 1 and 2, you either fulgurate or you excise those local peritoneal deposits and then start them on active treatment like IUI. But restoration of anatomy is the primary thing. But today, I will show you a different perspective of endometriosis, which is catching up so much. Like what I saw 25 years back is now turning into a real dilemma of how to treat or how to surgically do endometriosis. Now, presence of endometrioma is seen as usually a severe form of endometriosis. It may be just a tip of the iceberg. Sonography will just show you that there is endometrioma, but bilateral lesions occur in almost 19 to 28%. And as you go and operate, you will see more severe form of endometriosis. Now, endometrioma and involvement of DIE or deep endometriosis is almost in 22% of cases. Mostly the left uterosacral ligament gets involved. The left endometrioma is more associated with DIE and uterosacral. Bilateral endometrioma adhesions are occurring very frequently, and if there is bilateral endometrioma, even adenomyosis is very common as by several studies. Now, the incidence of pure D is just about 6%. Like this patient we just did about 2 days back. You can see the tube and ovary is absolutely normal. There is no endometriosis. But what is she having is a deep endometriosis. So any patient coming with a prolonged sterility of more than 5 years and sonography is normal, deep endometriosis is still a possibility, and many of them may not have really significant pain. And that is the problem when you treat this. Now, just now we heard Dr. Monica telling whether to operate or not. Well, if you're thinking of operating in a endometriosis patient, you have to have a full history. What is the basic symptom? Many a time you have surprises like appendix also getting involved in the adhesions. What is the pain score? Is the desire for fertility there? And what is the previous surgery? So this is very important, because all your decision will make on going to do is on these aspects which are going to be there. Now, if you're planning surgery on endometrioma, preoperative assessment is very essential, as she said. Indication for surgery, whether you're doing for pain or for facilitation of oocyte retrieval or infertility. But assessment of the ovarian reserve will become more critical. Ultrasound and AMH both are essential. Why operate on endometrioma? That is the biggest question the infertility specialist is going to always ask. With so many studies telling us that endometrioma should not be touched because of the falling in reserve, and the effect on pregnancy is still there. But this error study did mention to us, brought by Isilke et al., published in 2018, that endometrioma itself diminishes ovarian reserve, and AMH significant drop is seen in patients even if you do not operate. That is important. Well, the surgeon experience matters. Anatomical assessment is very important. You have to normalize the anatomy. You have to mobilize the ovary, identify the lesions, treat them, either excise or cauterize. And if it's a DIE, you should be an expert. So have a very formal approach. As you can see in the lower video, endometrioma of such a big size, I would put in the trocar to suck out the contents rather than it spilling into the pelvis, because so much of chocolate, if it falls, your vision becomes difficult and you can't identify all the endometriotic deposits, because the key is the first surgery is the best surgery. So don't miss any endometriotic lesions. As you can see in the upper part, the ovary is usually the one which is very much adherent with the ovarian ligament, and you need to pull it up, remove the thing totally. As you can see in the lower one, the pouch of Douglas adhesions, though this endometrioma looked okay, but adhesions already developed because of the blood and its product, and you need to know how to separate it from the adjacent structure without, of course, damaging the vital structure like ureter. And you can see even the right ovary, though looked normal, is showing some element of endometriotic cyst, collection of chocolate. Is make sure that you drag it well without tearing too much of the peritoneum, restore the anatomy, cauterize all those lesions in these patients. Now, whether to do cystectomy or not, it will depend on all the levels which we just mentioned. But such large cyst, you can't leave it because the recurrence rate is going to be very high. So you need to judge yourself how much cystectomy you're going to do. Monica did mention about the various sandwich therapy and so many other therapy which Taxilicas and Dones have, this near the hilum, don't remove the cyst. But in the few next slide, you will see what is the teaching today is. Of course, you can see such a large cyst. You need to do cystectomy definitely. You will identify the right plane, use sharp scissors to exactly locate the cyst and make sure you're not going to excise too much. But remember, the follicles are always compressed around the cyst wall, and you are going to remove some amount of normal ovarian tissue in endometriotic cystectomy, unlike the routine cysts like dermoid or cystadenoma, where the loss of ovary is not significant like you have in endometrioma. But this large cyst, unless you do it completely, remove the cyst wall, you have a very, very high recurrence rate. I'll come back to the way the cystectomy is to be done. Now, preserving the reserve is the most important. So surgical excision was always the preferred method, but as even the Cochrane did mention to us that the recurrence rate is less, dysmenorrhea, dyspareunia, everything is less, even the pain is less, spontaneous pregnancy is also less, but the requirement of gonadotropin during stimulation is always high after surgery. Even the requirement of future surgery is less if you excise. This is the data which we have. And we are talking, why should you remove endometrioma? But yes, identify the correct plane. Don't damage too much of ovarian tissue. Always use contralateral ports and go into the right plane with the right technique and try to minimize the damage. So preserving the reserve is very important. So going into the right plane and not inadvertently removing normal ovarian tissue, as you can see in this particular video, how we have kept so much of the normal ovarian tissue back and trying to remove only the cyst as thin as possible. Well, the other way of preserving the reserve is, of course, don't cauterize the whole wall after cystectomy. Localize, give wash, and only those bleeder points you may cauterize. You may mean, I don't think always cauterize. If the AMH is less, there are other ways of preserving the reserve. You do suturing. It has been shown that suturing is better than bipolar cautery, and you preserve the reserve by doing suturing better. So if you think you want to preserve the reserve, there are a lot of studies which say that just give a nice hemostatic sutures. And of course, you can use this vasopressin, diluted vasopressin, 1 in 200, hardly 10 or 20 cc. You can see how we inject with the thinnest spinal needle in between the plane, and the hemostasis is achieved because there is very less blood, and even the plane is very easy to identify, and you can dissect the tissues much better. So preserving the reserve, we use vasopressin quite a lot in patients whom we think cystectomy is going to be done, but inject it with the thinnest possible needle, and you can identify that the base of the ovarian tissue do not bleed, and you don't have to cauterize, you don't have to suture also. Even if you are bleeding, this epinephrine or noradrenaline gauze, if you keep it for 10 minutes, the bleeding will stop. So no need of cauterizing. So preserving the reserve, this is one important step. But before surgery today, you are not justified if you do not counsel the patient for cryopreservation, either of the oocyte or of the embryo if the partner is there. There are enough studies by Anna Lenberberg who said that presence of 20 mature oocytes, you have a good chance of future pregnancy. So this is what is very important today. With endometriosis increasing, it is always better to counsel the patient before you do surgery. So today it will be a crime if you do not counsel the patient of lowering the reserve, and there are options of oocyte. Now today, the scenes have changed from what I showed you today. Many a time, most of the time, we get this picture where total obliteration, everything is distorted, there is deep infiltrating endometriosis, and how do we treat even in young women who present with infertility, may or may not have dysmenorrhea, and that is where the surgeons, the traditional teaching was deep infiltrating endometriosis does not progress in more than 1 out of 10. I mean, 9 people do not have any progress, and complications which can be in the form of bowel, bladder injuries, ureteral injuries, neurogenic bowel bladder dysfunction, colorectal resection, anastomotic dehiscence with rectovaginal fistula, all are there. So no need of operating was the teaching couple of decades back. But today the current teaching is most guidelines now recognize the benefit of deep infiltrating endometriosis. Of course, it has to be done in a very recognized tertiary care center with a lot of multidisciplinary approach. And if you do surgery inappropriately, you may even worsen the patient's endometriosis and the bowel symptom. But today, there are enough studies to tell us that deep infiltrating endometriosis, of course, this NCCN classification, I wouldn't go into detail. It's available for all of. This is one which was released by Kekestan, a pioneer in deep infiltrating endometriosis surgery. I wouldn't waste time here going through, but you need to know the complete anatomy, vascular and nerve anatomy of the pelvis, the urinary bladder, the uterus and the rectum, all the hypogastric nerve, the sacral nerve and the parasympathetic nerve and the sympathetic plexus. We need to preserve them if you're going to go into the retroperitoneum in deep infiltrating endometriosis. So this neurovascular anatomy knowledge is very, very essential. How to preserve them when you're doing radical surgery is going to be very important. Now, preoperative preparation of deep infiltrating endometriosis, consent of everything, right from the bowel complication which can occur. You need to have a good surgical team along with the presence of a colorectal. Preparation of bowel is very important. Stenting of the ureter you may do if you're suspecting by the MRI report or sonography, ureteric involvement, and a good uterine manipulator, and of course a rectal probe is very required. Clinically, always do a perispecular examination. If you see such marks of uterovaginal or the rectovaginal nodule, you know that you are going to be very, very spending time and removing it properly. Do all the proper. Today, fantastic imagings are available by sonography, and you can do MRI, contrast CT. I wouldn't go into detail. And if you're suspecting mucosal infiltration, do a colonoscopy before you plan a surgery. Identify the exact location. Today, AI-generated images are also available in MRI to guide you exactly how much you're going to combine. Now, this original article by Sentini et al. Mentioned about the impact of laparoscopic surgery for deep endometriosis on pregnancy rate, and you'll be surprised that it gives a great news about if you're doing surgery in deep infiltrating endometriosis, spontaneous conception has occurred in almost 40%, and with ART, almost 70% do conceive if you do a proper surgery. Or patients not doing surgery, you can see the total conception rate is much less than 45% compared to the 70% after you do a surgery. So if you think you can do a good surgery, you are a great center, your center has all the other facilities, go ahead and do the surgery. Now, lab management and the pregnancy rate. Spontaneous pregnancy improves because there is improvement of sexual function, the positive impact, the quality of life, and as I already mentioned by Sentini et al., close to 70% pregnancy rates have been reported after primary laparoscopic surgery today in deep infiltrating endometriosis. Now, before ART, should colorectal endometriosis be done? This paper by Horace Roman and his fellow Bendifala et al. Have a great news. This definitely, they said that whom you will do. So this is very important in patients who have low AMH. Now this was seen in a patient. You can see nothing is seen. We attempted transfer twice, but we could not enter the uterine cavity. So we decided to go ahead, correct the anatomy, and you can see how difficult the surgery is. And after this surgery, restoration of anatomy was looking very difficult, but whatever best possible we could do, you can see how much deep endometriosis has affected her. She had undergone the surgery a couple of years back. On the first look, when we were the beginning, we said we won't do the surgery. Go ahead with the transfer after giving leuprolide depot for 6 months. But 2 transfers, I couldn't enter the uterine cavity, whatever I may try. But ultimately, we decided to go ahead, restore the anatomy, and you can see how ugly the uterus looks, but at least the uterus mobility was achieved. And subsequently, when we transferred, she did become pregnant. So that is where surgery before ART is still important in these patients who have low AMH. You can see the posterior surface. So much of the diseases has affected her pelvis and the uterine and the tubes. And definitely you can see the mobile uterus. So these are patients whom you would go ahead and do the surgery. Same Bendifalas paper did tell that overall pregnancy rate, you can see surgery and ART became 60%, and even the live birth rate was significantly higher than patients who were subjected to directly ART. So surgery plus ART gives better pregnancy rate than direct ART. Of course, you have to be trained in this. Now, what are the techniques of doing deep endometriosis? Patients who have colorectal, shaving, excision, disc excision, or bowel resection. Again, I will just touch upon this very paper by Donez and Ores Roman. There is no strong evidence for the exact risk of recurrence of rectovaginal endometriosis, either of the method you do. But one must do only shaving as the first surgical treatment because the bowel damage is less, the bowel dysfunction is less. So you need to identify where are the deposits. But for reanastomosis should be reserved only if there are multiple lesions or there is significant narrowing of the colorectal region. Then only you would do anastomosis, not just because it is there and you want to do it or you know to do it. Please don't do. Most of the papers do recommend that shaving should be the first line of treatment in every patient. So to simplify how to do deep endometriosis surgery, I'll take you step by step. First is adhesiolysis, erythrolysis, the ovarian surgery. I'll directly go down. This is, you start from the area which is clean. So this is a case of a deep endometriosis. You can always go above the pelvis where endometriosis usually doesn't affect. You identify the right plane, you give a good traction to the peritoneum, and you can see you can enter area which is not diseased. Just now Dr. Kamini Rao said it behaves like a malignancy, though it is not a malignancy. But if you start at the disease area, you had it, you will not be able to reach what you want to do. So identify, first is always the ureter identification in this pelvis area, because you need to safeguard the ureter first, apart from safeguarding the colon later. But identify the ureter, that is the primary motto. Correct plane. Once you trace the ureter, then trace it down till the urinary bladder. So I will be not, this is too much of a less time. Now you can see, we start seeing the ureter there. There is the ureter. So once we know that ureter is seen, we follow that. You can see the ureter is being lifted. You can see the ureteric peristalsis. Now follow this peritoneum, just dissect it, go ahead, and subsequently you'll see, once you have identified the ureter and safeguarded the colon, cystectomy, if required, you will do, keeping all those safety precautions of preserving the reserve, you will do to completely relieve the patient of her symptom. So this cystectomy is the same way which I just described. You may inject vasopressin, but make sure that you have removed the cyst wall completely as a primary surgery. I'm not recommending that second time surgery you should sit and do cystectomy. But after the cystectomy is over, you will keep the ovaries away. Now you have to enter the pouch of Douglas. You don't want the ovary to be falling in the center. So you have a lot of devices. You will see the T-lip device here coming through the port, a needle, and keeping because you need to ovary, you don't want an assistant's hand or a probe to be, wasted in retracting the ovary every time. You just hang it to the side walls and then go ahead and work in the center very peacefully. So this is the TLIP device. Both the side you apply and then go ahead and then start dissecting the pararectal space. You need to know exactly where the lateral border of the colon is or the rectum is. You will identify, and then you are taking care of the hypogastric nerve. Here you can see the hypogastric nerve, which is already there in the left border. Make sure that you do not damage it. Fat belongs to the rectum, so always go above the rectum when you are doing in the posterior compartment. Step by step, you may use Caesar or you may use harmonic, but whatever you are comfortable, but make sure that you're not adjacent to very, very important vital structures. So after the ureter is identified, the lateral border of the colon is identified, safeguard the nerves. You can see the inferior hypogastric nerve here on this side, and then you are seeing us going into the fatty layer. You can see this is not affected. So you have to, of course, make sure that the peritoneum is totally separated from because this is a diseased peritoneum. You will have to remove it at the last. Now, once you are very confident of doing, then the right pararectal space. So here we are again starting medial to the ureter, again on the right margin of the colon. You travel in the same way after identifying the ureter, keeping the fat to the rectum, remaining in the upper part of the peritoneum, close to the peritoneum, and keep traveling to the holy space, which I'll just be showing you. Then you can identify the pouch of Douglas. From before you enter the pouch of Douglas, make sure that the pararectal spaces are identified, separated. I'm sure you are appreciating that inside it looks that is the colon there. So you are making sure that the nerves are not damaged. We will just show you the all pelvic nerves very soon in this video. And once both the pararectal spaces opened up, then you free the pouch of Douglas of the adhesion of the colon. Here again, the same principle, push the work above the fat. Don't go below the fat because the colon is likely to be damaged. Here again, very small, gentle movements. You can see how safely you can enter. So only the confidence has to be there for us to enter into these difficult spaces. And today, with teaching and great imaging system, and of course, training on cadavers, all this is possible. So do first all these things, steps on the cadaveric dissection table before you can do it in live human patient. Here you can see we are entering the vagina is now seen. The pouch of Douglas is almost cleared off. The adhesion, you can see some of these endometriotic deposits on the surface of the rectum here. So then the peritoneal disease. Once the peritoneum is dissected, you need to remove the peritoneum. You can identify the ureter there, and you can just make sure that the complete excision of the peritoneum, it is done these days for better pain relief, for lesser chances of recurrence, and also less chance of affecting the adjacent structure later on, like ureter and other structures. So this is where the midline you can see just behind the vagina. This is much softer, where you know that the peritoneum is now free. You go on to the right side, and then you can see the pouch of Douglas is completely removed now. The peritoneum is completely removed. And then this is the final specimen of the left side and the right side. You may call it as butterfly and so many other names to it. But rectal shaving, you can see, you identify those pathology of endometriosis, lift it up nicely. You can see how safely we are going in between the muscularis layer of the colon and the endometriotic deposit, shave off everything. So this is a very meticulous step. Don't bother about those small oozers. Many a time they do stop. You give a good compression. You may take a very, very small stitch if the bleeding does not stop. or if the muscularis is damaged a little more. But this is how rectal shaving is done. But sharp scissors, don't use energy here, and remove every piece of the endometriosis. And again, ovary is to be suspended and kept. After the surgery, if you leave the ovary to the pouch of Douglas, the adhesions are going to occur. So what we do is suspend it into the outside abdominal wall. You can see the needle being straightened, and the stitch comes out of the abdominal wall, and the ovary remains suspended for about 7 days till the time the lower part gets epithelialized, and the chances of readhesion formation is less, and you can remove the stitch which is kept on the outside after 7 days, by which time it has been shown that epithelialization occurs. The raw area is not as bad as it used to be immediately after the surgery, and so the ovary going and sticking into that area is much less. You can see how the area is now looking. So this is one statement. First, good survey, sigmoid mobilization, ovarian mobilization, suspension of uterus and ovaries, ureterolysis, rectovaginal and pararectal space, and excision of all deposits. Now, this is the final view. You can see the ureter here. You can see on both the side. You can see the hypogastric nerve, the hypogastric plexus, superior hypogastric plexus is up, and then the two inferior hypogastric plexus, and those S3, S4 roots. You can see the sacral nerves, the parasympathetic nerves, all maintained. So this is very, very vital. These are the ureter, you can see. Then you can see the iliac vessels. So this is complete bare of the pelvis with great anatomy. You can excise other areas if it is there. Peritoneal endometriosis anterior, and you have done a complete job. And this patient will definitely have a better chance. Now, this is just a thing with the oleoplane pararectal space, which can be, here you can see the left inferior hypogastric nerve, the right one, the superior hypogastric plexus, and the ureter. So these are the final picture, the S2, 3, 4 nerve, the parasympathetic nerves, which all, and the Okabayashi space and the Latch-Go space, which is visible. Now, this is again, how do you enter? This is the external iliac artery. You enter between the iliac artery and the ureter and identify these spaces. This is just an animated view, how it should look like, the Latch-Go space, the paravesical space. So resection and anastomosis is selected patients when you have so much of stenosis of the colon, you can see. So this segment, you can't leave it like that. But before resection, you need to mobilize the rectum completely from the posterior attachment, also mesentery. From the vertebra, everything, it has to be detached. You think you want to resect, you can't just resect it. This is the sacral inferior mesenteric artery, which you have just ligated. And once you are mobilized, remove all the fat surrounding the colon. You can't have this because the anastomosis then will never become proper. So you need to remove all the fat which is surrounding this. And now, because of the stapler and other devices, the anastomosis has become much simpler or easier. Of course, it has to be done with the presence of the colorectal surgeon, and you pass it. Here you can see the anvil comes from the lower end. You have resected the upper segment which is required, and the normal colon which is there. You're going to do an end-to-end anastomosis with the stapler again. This can be done by the nose technique, intra-abdominal, or take it out, but then additional stitch will be there. And here you can see we have applied the stapler and the end-to-end anastomosis is finally done. Now this is the rectovaginal, of course, anastomosis. This is not, and then check the leak if there by putting copious amount of saline and no bubbles. So this is how the device stapler looks like, and this is the inside view of the colon at the anastomotic site. Of course, the patient has to be kept in the hospital for 5 to 7 days, making sure the bowel recovery is complete. And so bowel endometriosis, assess the depth of the bowel wall infiltration. If it's a superficial, which is only involving the serosa and muscularis, nodule shaving. If it's a full thick lesion of a single nodule less than 3 centimeter, discoid excision is advised. But if it's an extensive or multifocal with severe stenosis, resection anastomosis is to be done. But be experienced in this. Now, this is a very nice video of a very bad hydroureter because of endometriosis, extrinsic endometriosis on the ureteric wall. Again, a patient with a deep infiltrating endometriosis picked up, of course, by sonography. You can see the ureter so much dilated here. Very well. You can see them. Once we dissect more, you'll be able to see the stenosis and the narrowing of the ureter below that and the upper part going into hydroureter. But you need to go into the right plane just above the ureter. You can see the narrowed segment of the ureter and the upper dilated. You can see the endometriotic collection around the ureter. So dissect it completely, taking, of course, with all the precautions. You may stent the ureter either, and you can see the ureter is upper part is so much dilated, and that is the lower part. And you need to just completely isolate it and remove all the endometriotic deposits which is encircling that lower ureter and cut it off, excise it totally, and then the recovery will be much better. You can see the upper ureter which is dilated. This is the constriction because of the endometriotic deposits around the ureter, but you can see that we can correct it with all precautions. With, of course, don't try and cauterize them so close to the ureter. Try to just do with the plain scissor, and you can see the complete barement, and then some more deposits there around the ureter. You can see it is being removed with, and now you can appreciate the diameter difference between the lower part and the upper part. So this is where the endometriotic nodule was constricting the ureter so much that it had dilated above this. And so luckily this patient's kidney got saved. Otherwise, if many patients lose their kidney, stenting the ureter at this stage is important if you have not done it before, and leave it for some time, and at least 6 weeks we would leave it, make sure that, and then go above again in the laparoscopy. You can see more small deposits of the endometriosis, which with good traction, you identify the circumference of the ureter and make sure you have removed complete endometriosis. So friends, endometriosis is a lifelong disease. In the past, surgical diagnosis was done. First surgery, medical treatment, second surgery and ART. But today the teaching is diagnose non-surgically. You don't need a laparoscope to diagnose endometriosis with all the imaging which we have. It's a long-term treatment. First, do a good surgery or straight away take for ART, or single surgery and ART, but always convince the patient, counsel the patient, the treatment is going to be long-term. Don't leave after one surgery and tell you, okay, she will bounce back with such a severity disease. Thank you for a patient hearing. I hope I could cover most of the other topics, but it's a very, very long topic if I have to sit and talk to you about surgical aspects. But at least I've shown you glimpses of how modern endometriosis surgery should be tackled. Thank you.
Thank you, sir, for the very, very wonderful video presentation. And I had requested, sir, for one thing that, sir, we want lots of videos. And, sir, you have really given us a visual treat.
Endoscopic surgery cannot be without videos.
I know, yes, sir. Sir, but to be very frank, to, basic laparoscopic surgeons like us, it looks a little scary. So I'll start with a very simple question. So what is the learning curve? When you're progressing from basic laparoscopy to advanced, and then ultimately doing peritoneal dissections, retroperitoneum, fertility preserving surgeries, and bowel resections, discoid resections, what is the learning curve?
Now, first thing, I wouldn't tell that all surgeons should do bowel resection or rectal shaving, but no laparoscopic gynecological surgeon cannot become a surgeon without learning how to ureterolysis, how to identify the ureter, how to identify the important pelvic structure, the uterine vessels and the internal iliac arteries. So start with that basic retroperitoneal dissection of safeguarding the ureter, because every case, any hysterectomy, you need to safeguard the ureter. Today, you can't tell that I damaged the ureter and that is inevitable. No, not accepted. So start with that first and then progress. So start off with the cadaver dissection. As I mentioned, these are wonderful surgeries. If you practice them well, they're not very greatly difficult. Like say 10 years back, this was all difficult when cadaver dissection was not possible. Open surgery, we have never seen the retroperitoneum. So laparoscopic surgery has allowed you. So I would say that after you do the basic laparoscopic anatomy and simple surgeries, start with the retroperitoneum, identify the ureter, identify the uterine artery, and then go into the spaces. So have a mentor along with it, and then gradually, of course, it will take you a couple of years before you reach a level of expertise. But warning for everybody is don't enter into the abdomen doing endometriosis surgery if you're not sure of going into the retroperitoneum, because then you do a half-hearted surgery causing more adhesions. So whenever you're having endometriosis, call an expert who's in retroperitoneum and then start off. But of course, as bowel endometriosis, I'm not telling that I will do it alone without the colorectal's advice. It's a very, very big learning curve is there. But ultimately, if you safeguard these or follow this basic principle, it's a very simple surgery.
Yes. Yes, the points taken. And I think cadaveric surgery has given a lot of training opportunities to the people who are venturing into dedicated surgical expertise. Thank you so much, sir. Would any of you would like to put any question to sir before he logs off? Anuradha, any comments? Purva? Rekha ma'am? I think everybody is, totally mesmerized by your lecture and presentation, sir. So, sir, thank you so much. Thank you so
Sir,
much
I
for
have
your.
one question. Sorry.
Yes, yes,
Yeah.
please go ahead.
Sir, we are seeing nowadays that, bowel resection, doing a part of bowel resection and omental resection, it has become very common. There are many surgeons who are doing it. Are we correct in doing that kind of surgery? Will it help?
No.
Or
No.
is it reserved, for certain cases?
Even some of the world's expert center have hardly 3 to 5% of bowel resection in endometriosis surgery. But unfortunately, with the younger generation, definitely we are seeing every day 2-3 bowel being resected. And that is not, of course, a good sign, because bowel resection is not just cutting and leaving it. You have to know the future, how the bowel patients have the bowel complaints, how she's being suffering from it. So I don't think bowel resection is required the way the number which we are going through. Even some of the expert centers like where Ahmedabad, Dr. Sanjay Patel, I spoke to him, he said, no, we don't do bowel resection. Rectal shaving is the first preference. Only rare cases you have to do if there is no other choice. So definitely we are overdoing it. I hope we come back to normal census and stop doing this little extra bowel resection which is happening.
Thank you, sir.
Thank you. Thank you so much, Dr. S. Krishnakumar, sir, for
Thank
your.
you. All the best, Dr. Monica. We are all with you. I'm sure you have always been a winner and you will be a winner. Thank you.
Thank you, sir. Thank you so much for your blessings. So with this, we come to the end of the 3 lectures. And now the very eagerly awaited panel is here. Dr. Rekha Rajendra Kumar, madam, we offer our deepest condolences for your irreparable loss. And madam has been still able to join us. We are really thankful, madam. And all our condolences of all the Synergy colleagues and my Kasoga friends are with you, madam. So Anuradha is there to help you, ma'am, whenever you want her help. And please, ma'am, proceed with the panel. Virul and Purva, can you start the panel introductions?
So good evening, everyone. We are now at the last part of our webinar, which is panel discussion on the topic, dilemmas in fertility management in endometriosis, real life cases scenario. Moderator for that, we have Dr. Rekha Rajendra Kumar, ma'am. Ma'am is a medical director at Miracle IVF Hospital, Chandra Hospital, Bangalore, and also chairperson Foxy Medical Disorder and Pregnancy Committee 2628. We welcome you, ma'am. And for expert, we have Dr. Anuradha Khar, ma'am. Ma'am is secretary at ART Committee Kasoga, secretary at Kisar, and managing committee member Hisar. We welcome you, ma'am. Next, we have Dr. Mahesh Korgol, sir. Sir is director at Nova IVF Fertility, Bangalore, and also president at Bangalore Obstetric Society. Welcome you, sir. And for panelists, we have different doctors like Dr. Lavanya Kiran, ma'am. Ma'am is dignitary at Kasoga. We welcome you, ma'am. Next, we have Dr. Manjula Patil, ma'am. Ma'am is treasurer at Bangalore Obstetric Society. We welcome you, ma'am. Next, we have Dr. Manjunath CS, sir. Sir is Birla IVF Fertility Center. We welcome you, sir. Next, we have Dr. Nivedita Shetty, ma'am. Ma'am is past president Kisar. We welcome you, ma'am. Next, we have Dr. Priyanka Varvate, ma'am. Ma'am is secretary at Basava Kalyan Obstetric Society. Welcome you, ma'am. Next, we have Dr. Raju V. Giradi, sir. Sir is secretary at Raichur Obstetric Society. We welcome you, sir. Next, we have Dr. Shilpa Harish, ma'am. Ma'am is chairperson at ART Committee Kasoga. We welcome you, ma'am. Next, we have Dr. Sindhu Lakshmi, ma'am. Ma'am is secretary at Mysore Obstetric Society. We welcome you, ma'am. Next, we have Dr. Vijay Kumar CR, sir. Sir is secretary at Bangalore Obstetric Society. We welcome you, sir. Now, I request our panelist and our moderator to start the panel discussion.
1 minute, I would just like to give, madam, just before you start, I would like to pay my respect and welcome to Shanta Durge, ma'am.
Yes, ma'am.
Vishal, please can you put madam's CV on the screen? Madam has just joined. She is a guest of honor, esteemed guest of honor. President Basava Kalyan OBGY Society, a very senior FICOG of the ICOG Club, a keen academician, and I pay my respect and regards to Shanta ma'am. And madam, we would like to have a few words. We are nearly at the end of your program, but it is so nice of you to join. Could you just speak a few words to us, madam, to encourage us and bless us?
Hi everyone. Hi everyone. Myself, Dr. Shanta Durge, and Dr. Monica. I heard Dr. Monica's presentation, and it was really, really very good. And even Dr. Krishna Kumar also so informative. And I wish all the best to Dr. Monica Singh. Thank you. Thank you.
Thank you. Thank you so much, Shanta ma'am. We would really appreciate if you could stay on in the panel and give your inputs. Rekha madam, you can share your screen now.
Yeah, I'm doing that. Thank you, Dr. Monica, for the opportunity, and I really could not back out in the last minute, so I'm here. I'll do my best as far as possible, and I will proceed here. Is it seen, my screen? Is my screen?
No, ma'am.
Not yet. Not yet, madam.
Share.
Yes, ma'am. Now we can just, it is started screen sharing.
Yeah. Is that fine?
No, we are waiting for the slide to come, madam. Yeah, it has come. Yes.
Okay.
Yes.
Fine. Yeah. I start here. Thank you, Dr. Anuradha and Dr. Manjula, for being with me as the experts to conduct and moderate this panel. Also, thank you all the panelists for joining here. I'm not very sure how many panelists are there. I can see Dr. Lavanya and Dr. Shilpa. I don't know about the other panelists. If there are no, some of them are not there, please let me know.
Madam, we are there in the panel. Virul and I, we will participate in the panel. Anuradha is there as expert, and I will let you know.
Lavanya is there, and Dr. Shilpa is there. I could see. Rest of the panelists I could not see. Anyway, let us proceed and let all of us participate together and give our opinions as we move on.
Madam,
Hello?
Dr. Sindhu Lakshmi is there. Dr. Sindhu Lakshmi is there.
Yeah.
And
fine.
Dr.
Sim is there. Yeah. Fine. So this is a very famous saying from William Osler. He said, "He who knows endometriosis knows gynecology." This was very clear, and I'm sure that you have totally endorsed with me with the previous two speakers, Dr. Krishna Kumar as well as Dr. Monica, about this. These are all the different spots of endometriosis. I'm not talking much, just the very few introductory slides. These are all the places with the percentage of how much endometriosis can occur. 34% in the pouch of Douglas, means the most common place probably is the pouch of Douglas. Coming to statistics, 25 to 50% of infertile women have endometriosis, and about 25% conceive after the surgery. These are all the different spots. We should not miss the spots, especially when we put a scope. The small white patches, etc., may be endometriosis also. So we should be very keen to check all the different folds, antevert the uterus, retrovert the uterus, check the posterior leaflet of the broad ligament, etc., etc., not to miss. The different forms of endometriosis are here. Now, the first question, Dr. Lavanya, you can take this question. What are all the, I will come to the case presentation after a few questions like this. What are the factors which you consider we are talking only about the infertility aspect of endometriosis. We are not talking about anything beyond this. So what are all the factors which you consider during the management when a patient comes to you as complaints of infertility, as well as you have made a diagnosis of endometriosis?
Thank you, Dr. Rekha, for this wonderful question. And I think I'm very happy you asked me this question because as a fertility specialist, I have a lot of factors for myself to consider when patient is diagnosed as an endometriosis. First, I would say size matters to me if you're looking into investigations. Size and how big is it? Next, very important for me is what is the age of the patient, how long are they married, and what are the symptoms she has if she's done any fertility evaluation as she checked on her AMH, FSH, what's happening, does she have a previous history of surgery? All these things matters for me to decide if it's very big, then do I need a surgery or do I offer her fertility treatment first or do I offer her a surgery? I think these are all something very important for me to ask, and also her pain is something very important for me.
Yes. Also to add other factors, not to forget, like the male factor also. We may be talking about the female and we may be talking only about the endometriosis, but it will be an added or a compounded hindrance when there is a male factor. So our decisions also may vary. Now coming to the proper case presentations, I have put to the case presentation Dr. Monica. If at all there is any little bit mental disturbance from my side, please let me know. To all of you here, I lost my mother today and I'm coming directly from the crematorium. I did not want to miss this because I had promised Monica. So if at all I do some mistakes, please excuse me. Okay, so I'll continue.
It's okay, madam.
Yeah, please. I'm very sorry. I'm continuing with my case presentation. Mrs. NKS, 29-year-old, Dr. Shilpa can take this. She's consulted us for the dysmenorrhea and primary subfertility. So laparoscopy was done just 20 days back, showed mild endometriosis. We don't want to go to what is mild, etc., because already explained. Spots we could see, which I showed in my picture, got fulgurated. Also, DHL was done, definitely has to be done as a part of infertility workup. Normal hysteroscopy, and we're happy with the tubes. Ovarian reserve and male parameters were also normal. Young woman, primary subfertility, tube and male parameters are normal. What would you do? How will you proceed with this case? What is your treatment plan, Dr. Shilpa?
Thank you, Dr. Rekha. This is a case of primary subfertility. They've been trying for 4 years and there is a factor of endometriosis. I will treat her like a case of unexplained infertility, where I will definitely go ahead with ovulation induction with letrozole and an IUI. Of course, I would like to do a tubal evaluation. I think the tubes were fine, if I have not missed. If the tubes are patent, would like to go ahead with ovulation induction and IUI program for her for, say, 3 cycles.
Yeah, for all the audience, benefit of the audience, what we want to tell here, emphasize with this case is that though everything is normal, once you have diagnosed endometriosis. However early the endometriosis is, like stage 1, you have to tell her during counseling that promote for fertility. You push her for some kind of treatment. Don't allow her to sit at home and try for natural pregnancy, because having pregnancy is very beneficial to her in the very beginning, that is the first 6 months post surgery, like your fulguration, etc. Take the advantage of this first 6 months than wasting that time. So the medical management like OCP, Dynagest, we don't want, because we're talking only of infertility. As Dr. Shilpa said, it is controlled ovarian hyperstimulation and IUI. That is what we advise them. So Ishre said COH, that's controlled ovarian hyperstimulation with IUI, should be considered within 6 months following surgery in the treatment of these subfertile women. And this is the statistics saying that the fertility rate is increased 3 times when you do some kind of treatment like IUI. Dr. Anuradha, do you want to give some input here as an expert? Is Dr. Anuradha here?
Yeah. So, yeah, I agree with you. Anyways, we have been traditionally also following grade 1, grade 2 endometriosis, we go straight for IUI. And if it's higher grade 3 or 4, we do IVF directly. Plus, as you said, 4 years she has not conceived. So there is something which is playing there. And before laparoscopy, I'm sure she must have been diagnosed as unexplained, but they have seen the endometriosis. So we should not waste time. And roughly 3 cycles of IUI, definitely we can try. She's very young, AMH is normal. We have to counsel her and start that.
Yeah, we have to counsel her. It's a consecutive 3 cycles of IUI. That is what matters in this case.
Dr. Mahesh Paregol is also there, Rekha madam. He's also our expert.
Fine, yeah, but I could not see him. Yeah, we'll take his opinion after the second case. Mrs. SR, 36-year-old, primary infertility, married for much more, that is 10 years. Of course, because it is 10 years, she's very keen on pregnancy, slightly towards the older age group, that is 36 years. Again, male factor normal, tube assessment done 5 years back was normal. Recent transvaginal scan unfortunately showed a 6 centimeter right endometrioma. AMH reasonably okay, 1.1. And what is the treatment? Who is there? Dr. Sindhu Lakshmi, do you want to take this question? What is your treatment plan? Bit different from the first case where she did not have the space occupying lesion. Here she is not as optimal or not as good as the first case, the second one.
Hello, ma'am.
Yes.
Ma'am, this is quite a dilemmatic situation like we face in the routine, not in the routine OPD. So here we see that this lady has had around 10 years married life and she has been having difficulty in conception. And the recent scan is showing endometrioma. So this goes into this, the deep endometriosis. So sir also briefed on saying that if there's a difficulty in oocyte retrieval, then it's always better to go ahead with the surgery than the medical management. So I would prefer a surgical management followed by the IVF.
Okay, you mean to say you want to do the laparoscopy first, tackle the endometrioma, and then go for IVF, or laparoscopy, tackle the endometrioma, and go for IVF? What is your combination?
I would prefer to do a laparoscopy because it's a big endometrioma, more than 4 centimeters. This is going to interfere with the oocyte retrieval also, and also difficulty in ovarian access. So, and then after that, I would plan a IVF.
Any other panelists want to opine on this, differ from her?
May I know the AFC?
AMH and Dr. Rekha, if we're seeing the picture, it's definitely looking more than 4 centimeters. At least the picture looks a bit.
Don't exactly correlate with that. This is a picture just to say that it's an
Okay, perfect. If it's 4 centimeter and if I feel that the antral follicle looks good to me and it's accessible, I really don't mind, going ahead and giving her IVF, because we as fertility specialists, I think we know how to tackle with a little push and pressure on the abdomen. We'll still be able to do an ecpica. If our AMH is much lower, I would definitely put IVF as my first priority. If AMH is excellent and then it's going to interfere, if I feel through my scan that it's going to be there, then I would put up, because when we're doing endometriotic surgery, I think it's very important. The first surgery is going to be always the best surgery done for the patient. It's not about just draining. We have to remove the cyst. I think we heard wonderful presentations from Sir as well. So when we're doing this, we can strip a lot of normal tissues and AMH will drop down. Chances of pregnancy also comes down. So I think it's something with AMH, everything needs to be taken into consideration.
So ultimately,
think
what
in this particular
Dr.
case,
Lavanya-
Dr. Rekha, in this particular case, you already said her AMH is 1.1.
Definitely,
So
IVF
I
will be a
agree with
better
Dr.
choice for her.
Lavanya that I would, I mean, of course, in the other ovary, we have to check what is the antral follicle count, basically. And if it's a good follicle count in the right side, we will definitely get some eggs out of it. So I would stimulate directly and get out some eggs and freeze the embryos and then later see what is to be done.
And nothing is written, that means rest of the things are normal. And Dr. Sindhu, there is difference of opinion between you and Lavanya, and I will definitely go by what Dr. Lavanya says. That is actually the latest, and that is the right way of treatment. Dr. Sindhu, I ask Dr. Mahesh to opine on this.
Dr. Korigol is commenting something.
There are
Sir,
two
please.
indications for surgery according to all recent guidelines, British guidelines, the ISHRA guidelines. Two indications for surgery in endometriosis with infertility. One, if you are not able to access the follicle. I think even the 10 centimeter follicles also you can access with the abdominal manipulation. That is indication number one. Indication number two is a severe pain. If pain relief, yes, the surgery is needed, or if you are not able to access. So as per British fertility guidelines, as per the many guidelines, there are only two indications. Other
And
than
there is
this,
a risk of malignancy. Third.
yeah, that is because here is the fertility is concerned. First thing is take the eggs out, make the embryos, then remaining things, because there is a higher chance that all the studies says that AMH is going to be low. So there is only two indications. All the fertility guidelines say that pain and inaccessibility. Otherwise, no role of surgery. So especially in this patient, absolutely no role of surgery.
Yeah. So Dr. Sindhu wanted to go ahead with laparoscopy. Do you think there are any advantages over the first line as IVF?
No. I agree with that. I didn't see the whole list over there. It got skipped. AMH is low. I would actually prefer to extract the eggs and then go ahead with it.
Yeah, Dr. Sindhu. Dr.
Can you hear me
Sindhu, I
now?
can't. Patchy, please go ahead.
I think network issues. Ma'am, the AMH is low. I totally agree with Dr. Lavanya's plan. The surgery, as Sir told, is indicated only when we are not able to access the oocytes. So if you're able to access the oocytes, it's always better to go ahead with the.
But then I can play Sindhu's devil's advocate. And if I stick to Sindhu's plan and say, yes, I will agree with Sindhu's decision, we can go ahead. See, if patient is having pain and inaccessibility, definitely patient is going to have a better pain. Quality of life will definitely be better. And then only thing is being precise and trying to make sure there is no delineation, like water dissection we can do so that your cyst is coming out, your normal tissues are not damaged, cautery not to be used. These are all some plans that we can do through laparoscope so that the pain is much lesser for the patient and we still retain. And best is because a lot of endometriosis, what happens, cancer chances are very high. So you have a histopathology which is not going to risk the patient's issues.
We will talk about that
To
in
just play
future
Sindhu's
slides.
devil's advocate, I am.
Yeah, of course, there are advantages of laparoscopy, but since we are orienting ourselves today towards the fertility, giving the take-home baby is the word. That is what we are aiming at ultimately. So in spite of having all the advantages, we are concentrating on fertility, and laparoscopy does not take the first place. Fine. So laparoscopy is a gold standard for the diagnosis of the endometriosis, not for the treatment part. So these are all the statistics about the laparoscopy. Patients with complete removal of endometriotic lesion had spontaneous pregnancy rates of 25%. There are a lot of statistics going on about laparoscopy. So move on to the next question. This is about the second case and also about in general indications for the surgery. That is ultimately tackling the endometriosis, that is DIE, or the endometrioma. Who wants to take this question?
I think
Dr.
Mahesh has
Manjula?
already answered this question.
Yeah, same
Yeah.
thing. It's risk of
Yeah,
pain.
yes,
Go ahead.
size.
Size.
This was a previous opinion. I just put that answer because that was so. But now we, even if it's a 8 centimeter, as Dr. Lavanya said, we go ahead. Now the 4 centimeter is not there anymore. Inability to access the follicles if there is a concern of occult malignancy, as Dr. Shilpa was telling. DIE if it's causing obstruction to the ureters, etc. So these are all the different indications for the surgery. So should all the endometriomas be excised? No, we already spoke about this irrespective of the size. Now coming to this question, the endometrioma is more than 4 centimeter. In this woman, we have already told about that. Now you have decided for the oocyte retrieval also. That is what the consensus of the panel. Now what are the difficulties in oocyte retrieval? Dr. Manjula Patil is there? Dr. Priyanka is there?
No, madam, they are not there.
Okay,
I'm
fine.
only the
So Dr. Shilpa?
Yeah, difficulties, we have to be very careful in doing the oocyte pickup. In case we puncture the endometrioma, it can cause infection. We may end up having ovarian abscess, and that will be totally devastating for the patient. And also, if the endometriotic fluid gets mixed with the follicular fluid, it will affect the egg quality. So OPU has to be done by a senior person, or somebody who's really good in OPUs should be doing the OPU with cases of endometriosis. So this is the precaution that we have to take. It is not difficult. We have to be meticulous, and we have to have that much of expertise in doing OPU for these kind of cases. Inadvertent puncture is not warranted, and in case it happens, we have to cover the patient with good antibiotic coverage, and she needs to be under observation.
Yes, we said that we don't want to take the patient under knife. We were all of the opinion that the ultimately get the embryos done is what we all opined on. That was a consensus, because there are a lot of disadvantages of the surgery, and Dr. Lavanya has already explained about this slide that however good you are at surgery, however you have dissected the plane, in the bloodless plane you are, etc., and you do the cystectomy, the healthy ovarian tissue that was subjected to the histopathology had the proper, nice, healthy follicles. So ultimately, it is going to reduce the fertility of that woman. So although surgical excision gives satisfactory pregnancy rate, the concern about removal and ovarian reserve is there. So that is why we don't want to go for. Okay, now we have some cases, of course, we decide to operate, or some cases we don't operate. There are advantages of both. Of course, the concerns was entirely different. If you operate, these are all the advantages, and this, if you don't operate, these are all the things. Like if you operate, better IVF, again, according to some people, prevents rupture because you've removed the endometrioma. There is no ultimately contamination. The endometrioma is not there when you are doing the egg pickup. When you don't operate, the endometrioma is there. You have to be having a more expertise to get the follicles, I mean the eggs, in spite of having the endometrioma there. So what are the indications for IVF and ICSI in case of endometriosis? Anybody can take this question. Dr. Priyanka is there?
No, madam, she's not there.
Dr. Anu, you want to opine on anything till we finished?
Of course, one is that the higher grade the endometriosis, grade 3, grade 4, I'll directly go for IVF. I will not even try IUI for such cases. If there is a severe male factor, oligoasthenozoospermia, or we have teratozoospermia, we are going to go for the IVF ICSI only. And if AMH is lower, on the lower side, it is a direct IVF. If the patient's age is more than 35 years, definitely I would like, and the AMH is low, the reserve is low, then I will go for ICSI. Of course, if she has already taken past treatments like ovulation induction with timed intercourse or with IUI outside, and she has not conceived after 3 cycles of IUI also, then I would like to go straight away for the IVF.
Yeah.
Yeah.
So somewhat difficult cases, somewhat advanced cases, compounded problems, all these cases, we directly go for IVF ICSI, that to ICSI, than wasting our time beating around the bush. Thank you, Dr. Anu. So now the question Lavanya can take. What is the role of counseling, Dr. Lavanya, and what are the points do you emphasize on when you counsel these patients?
I would say counseling becomes one of the crux, because these are all very, cat on a wall situations, sometimes surgery, sometimes IVF, because the advantages, disadvantages of both are there. So what happens when during counseling, we need to tell them as days are passing, AMH reduces, quality of the oocytes are also much lesser with endometriosis. Implantation failures are there because of the inflammatory. So I think these are all something that we need to remember if we're doing an IVF. If we are doing a surgery, I think we have to tell them that reduction of AMH, stripping of the normal ovarian tissue is quite common, additions are quite common, and recurrence is something very, very common. And I think informed consent is very, very important for her.
Yeah, and the pre and post-operative AMH estimation. Some people do after the surgery, about 3 months after the surgery, they check the AMH, etc. But at least 2 samples pre and post are very much necessary to explain to the patient. Thank you. So the different kinds of surgery, we know we don't have to go about the different, like the conservative surgeries or a definite kind of surgeries, etc. And the advantages and disadvantages of ablation versus cystectomy all have been explained by the previous. The cyst aspiration, it's a kind of half-hearted surgery we do just to kind of a decompress. The chances of recurrence is very much high, but the stripping is not there, so the fertility is not much reduced with this, because we are not taking chunk of the ovarian tissue here. Now, what are the limitations of the surgery? Somehow you have gone and subjected the patient for the surgery. What are the limitations of the surgery for the endometriosis? Dr. Sindhu? Dr. Sindhu?
When we counsel for the, is somebody answering? Yeah.
Dr. Monica, you can take this question.
Yeah.
Madam, I was not.
Okay. So I'll take it, Dr. Rekha. If
Sorry.
there is one, you have to tell the patient that there is a risk of recurrence. Chronic endometriosis is a chronic disease. It's a recurring disease. Second, I would say that, even despite good surgery, pain may not come down in all the patients. So we should not promise that, we do surgery and pain 100% will go away. So she will have little pain relief, but, over a period of time, it may come back. And of course, the permanent changes, what has been caused, say, on the tubes, we cannot correct those tubes if they are damaged in endometriosis or there are severe adhesions. We're not able to, save those tubes. So we have to tell them that, we can't promise the tubal, repair and all. Okay. So, those are the limitations of surgery.
Also, it needs to be done from an expert surgeon.
Yes, Rekha ma'am, the golden period post surgery is
by an expert surgeon.
Yeah, we should also tell her about the either to prevent recurrence or to reduce the pain or to maintain the optimum fertility. We may have to put her on, and most of the times we do put her on post-operative medication also. Let her not think that surgery is done and everything is finished and within 6 months I'm going to get pregnant. So we have to explain all this, the limitations of the surgery. Now, what are the
Another
situations?
thing important is that they should not get lost in follow-up. These patients should come for follow-up regularly, have their scans evaluated again after 6 months, and see if anything new has come up.
Surgery related to the pregnancy rates, natural pregnancy rates, it may not increase the IVF success rates. That should be inform
Yes.
the patient.
Can you take this question, Monica? What are the
Yes.
situations where surgery is better avoided?
Like Dr. Shilpa has correctly said, that surgery, according to evidence and according to what we practice, has got a golden period of 2 years, 1.5 to 2 years, when the patient may have a spontaneous conception and she responds very well to controlled ovarian stimulation with IUI. So you can plan good cycles if tubes are patent, if semen parameters are normal for an IUI, or even if it's a young patient with other good fertility factors, you can even try for a normal natural conception. But the recurrence really escalates after 2 years. So you have to stick to that golden period when she can have and post surgery. There is no evidence that IVF will cause better results, will lead to better results. Post surgery, IVF results will have the same clinical pregnancy rate and cumulative live birth rate as those patients who do not undergo surgery. So
I
that
would be
was
a bit different from you. I would be a bit different from you, saying that either it is IUI, COH plus IUI, or IVF than giving a natural way. Like, I will not allow her for only natural way
No,
because we have made a diagnosis of
Depends
endometriosis.
on the age, AMH, AFC.
Yes,
yes.
so
And
many
actually,
factors are
don't
there.
tell to wait and watch. Some patients actually they refuse treatment for some time,
If they
and in that
refuse, that is
waiting period
their
of 6
problem.
months, you might conceive. In that waiting period, sometimes a particular couple they conceive.
Yeah, hardly any, but your counseling should not be on the natural conception. Okay,
Yes.
fine. This is everything put in nutshell, the benefits and the risks of both expectant as well as the surgical management. Again, I will not go into the details of this. Anybody wants to take this question? This probably has been told earlier and many times we have discussed this. The precautions to be taken during the egg pickup, because we decided that many of the times, however big the size of endometrioma, we are going to proceed with the egg pickup in the presence of endometrioma. So what are all the precautions? Dr. Sindhu?
I
Dr.
think
Priyanka?
she is not
Anybody
there.
can take the question.
Yeah, I think it's very important that we avoid pricking or going through. So that's the most important thing. And second important thing is accidentally or incidentally you end up going through the endometrium, sorry, your endometriosis. You have to better change the pickup needle will be better. Until unless sometimes cost of the patient we're considering or something, you can flush it always, but don't try to use it simultaneously going through your endometriosis and then go through a newer follicle. These are something I think will be very important for us to see and follow up for the patient, because sometimes you've gone through abscess is quite common, pain and all can be aggravating, so follow up is also something very, very important for us.
And inadvertent puncture, immediately we should change the tubes. Make sure the follicular fluid doesn't get mixed with the endometriotic fluid.
See, first and foremost, we should do the normal ovary which doesn't have the endometrioma. Once we get good number of eggs, and if that endometrioma is in the front, like where you enter the ovary, and some of the 2-3 follicles have grown behind it, I think you can leave that ovary also rather than going through that endometrioma. So always do the one ovary which is normal, and if you get good number of like 5-6 eggs also, you should be happy about it rather than causing problem to this patient.
We can go through laparoscopic approach also if need be, and if we have not got sufficient number of eggs.
Yeah, if you can really avoid that touching that endometrioma and can procure the follicles, that is what we aim at. Dr. Mahesh, you want to tell something here?
The most important point is not to touch the endometrioma. So it is possible. I understand it is difficult. With the abdominal manipulation, you have to take the oocytes which are only accessible. Second is, sometimes some oocytes are not accessible. Them you can leave, because even couple of oocytes, you have to counsel this before you do the pickup. Before you stimulate, you have to tell the patient that we might be in a situation wherein we may have to do this. So second is, when we are doing it, do a safe practice, which is more important, because safe practice is always important, because we have seen the cases wherein there have been abscesses, there have been lot of difficulties. So once you enter, then you can't do anything. Aspirate completely. Accidentally, if you enter by chance, what to do is the question. Do not leave it because it will leak out and then abscess formation, all that's the problem. Accidentally, if you don't inject, but if you go into it, then you have to aspirate it completely, whatever you have gone it, and then you have to do it. Most important point is leave the follicles if you can't exercise, that is fine. Couple of eggs will be less. Don't concentrate on emptying all the ovary like other cases. So let us not do it. It will be safe practice is always more important here because complications are more detrimental. So that is.
Yeah, tell her to report to you if she gets some pain abdomen, some fever, a loss of appetite, because be very, very careful about the early diagnosis of pelvic sepsis, the ovarian abscess, etc. Dr. Monica, you want me to stop here? You said 2 cases, that's why I'm asking.
Madam, we can take one more small case. I just wanted to ask one practical question to my experts and to moderator, madam. Madam, has practically anybody seen an abscess forming in a case of endometrioma? I have never seen an abscess, though I have punctured a few endometriomas, small ones.
I have
multiple.
seen 3 cases done outside wherein they really were bad situation, really bad situation. So they came to us saying that pickup was done. Then we had to put a scope. Then the whole OT was foul smelling. OT could smell. The moment you put a scope, the smell was so bad in the OT, you just couldn't stand there. That kind of abscesses we have seen. Yes, once you pierce endometrioma, don't leave it behind. It's going to be complicating further.
Okay. So, sir, suppose inadvertently we do pierce a small endometriotic cyst, or we get the blackish fluid in our tubes. Do you prefer post pickup to put the patient on IV antibiotic? Keep them Enflon?
Any high dose antibiotics, IV need not be, oral also is good enough. Any high antibiotics is good enough. So the more than that, we have to empty it completely. Then keep vigilance that there is abscess formation. You have to tell the patient, and we have to be vigilant.
At least give 1 dose of IV antibiotic when you send her home.
Yes.
The
Anyway,
higher
Because she's in the
dose,
hospital, I think cover her with 1 or 2 doses and oral antibiotics will fit.
and be very watchful.
Yes.
Fine.
True.
Yeah, this is a bit different case. A 32-year-old woman, software engineer, 5 years of married life, cycles are very regular. Severe dysmenorrhea since adolescence. She presents to the clinic with history of recurrent episodes of cough, chest pain, shortness of breath, which is very much cyclical during menstruation. So mild hemoptysis during these episodes. Describes pleuritic chest pain also to the right side, worsening during periods. Each episode is about 5 days, and after the menses that stops, and there is no history of anything suggestive of tuberculosis. And dysmenorrhea significantly affecting daily activities. Underwent laparoscopic cystectomy 2 years ago for an endometriotic ovarian chocolate cyst. This is her history. So what is your probable diagnosis and how do you want to investigate this case?
I think it is quite, I would diagnose as maybe like pleural endometriosis is something common, and CT is something that we can do. Medical management, I think, will help. I don't believe in doing CA-125 because CA-125 will increase with any, it's an inflammatory marker kind of a thing. So
yes,
I would say for AMH, everything is normal. Maybe we can look into a medical management for some time, see if the symptoms improve, then go ahead accordingly.
Yeah. So we have put everything here about the case. Laparoscopy to assess the pelvic endometriosis and rule out diaphragmatic involvement, and the other surgical like VATS for the pleural biopsy and lesion excision so that you have a final diagnosis, and fluorodesis in case of recurrent pleural effusions. We also have the medical management here like the OCPs, etc. Definitely this is much before you take her for fertility treatment so that the problem comes down. So about this woman, her AMH is 1.9, FSH was little more, LH 6.2, AFC was both ovaries together moderate, that is I can say 8 to 9. She was managed with medroxyprogesterone acetate on long-term basis. During this time, oocyte retrieval was done by PPOS protocol as the patient was already on medroxyprogesterone 4 blasters were obtained through transfer by HRT FET cycle, and the beta HCG was positive, and she delivered by LSES. Just wanted to put that case. Want to proceed, Dr. Monica?
No, ma'am, it's okay. I think it's 8:45. We can call it a day. And I think we have discussed
Cases may continue.
extensively.
Yeah.
And we really appreciate your, madam, your strength in conducting this panel in today difficult time for you. And
Thank
all
you.
our
I'm very sure that I was not optimum. I very much know that I'm not at all optimum, because I made presentation little earlier, and today now I'm sitting right in front of laptop. So wanted to refresh and then proceeded, not fully prepared also.
Dr.
Except-
Rekha, I think you were wonderful as a web moderator. I think you covered the cases so well. Every
Yes,
point was
yes.
touched upon.
Yeah.
You're really
Thank
good.
you, Lavanya. Thank you so much.
And
for
Dr.
understanding.
Rekha, heartfelt condolences from
Yeah.
all of us
Condolences to
here
you.
Okay.
and from Karnataka chapter of ISAR also.
Thank you. Thank you.
And I really thank our experts, Dr. Anuradha Khar, Dr. Lavanya, Dr. Mahesh Korigal, and Dr. Shilpa Aresh for the inputs. Dr. Sonia has been with us, Dr. Sapna Kale, Soumya ma'am, Suman Gaddi madam, and Dr. Madhu Kiran. So I really appreciate all of you for staying with us. We are nearly now 4 hours into the webinar, which is, a really great thing for a Monday evening. And Sonia ma'am, you were saying something.
I
Please.
was saying I should congratulate Dr. Rekha, but in spite of that, tragedy, she still made it. That shows her professional capacity.
Thank you.
Now, madam, yes, you did mention about that case about the ovarian abscess. Dr. Monica was
Switch on the
also
video,
asking.
Sonia. Switch
Madam,
on your video. Okay,
I'm
fine.
actually traveling, so I thought I'm
Fine.
just traveling.
However comfortable you feel.
Yes. So I was, yeah.
Yeah, we can hear you, Sonia
Yeah,
ma'am.
you can. So we had 2 cases passed last 1 year with a tubo-ovarian abscess. So actually, initially it was diagnosed as hydrosalpinx. The patient never gave us the history of an IVF attempted cycle. So after getting into the history, though we know the overall incidence is just 0.1 to 0.6%, but still, I think we should keep in mind, so many a time these patients will never reveal the history. Though it was an IVF cycle, it took almost 2.5 hours for them to let us know about the details of the history. So it was just a tubo-ovarian abscess, and after the reports were got in, and then CRP was positive, and after a diagnostic laparoscopy was attempted, that is when their attenders have come and actually told us that it was an attempted IVF cycle and it was a failed cycle. So sometimes I think clinically we encounter these kind of cases also, and it was very nice for Dr. Rekha to put up that case.
Okay. Thank you. Anybody wants to give any inputs?
Thanks a lot. Sorry for your loss, Dr. Rekha. Please take care. It was a wonderful session, Dr. Monica. Thanks a lot, everyone.
Thank you. Thank you to all of Kasoga, all dignitaries, and thank you to Kisar also. I feel it is a Kasoga plus Kisar initiative. And thanks to my friends, my mentors, my seniors, my colleagues, and announcing the next 33rd episode of Synergy is with great speakers. It is on 1st of July, Doctor's Day. We are trying to do with whole of Maharashtra, which is going to be double the attempt of Kasoga, but it's just we are going to make an attempt. And our keynote speakers are Dr. Jatin Shah and Dr. Pratik Tambe. So look out for a totally bombarding session on 1st of July, Doctor's Day. Thank you all and have a great week ahead. Thank you. Thank you.
Congratulations, Dr.
Thank
Monica,
you.
and all the very best.
Thank you
Humbly-
so much, Monica. Best of luck.
Humbly seeking blessings from all of you, but especially my voters, Rekha ma'am, Mahesh Korigal sir, Sonia madam, Sapna Kale ma'am, the presidents and secretaries of Kasoga, and the Foxy dignitaries who are going to be voting for chairpersons. Thank you so much. Thank you so much.
All the best.
Take care. All
Thank
the
you. Thank
best. Bye-bye.
Thank you. Thank you, Vishal.
Yeah.
Thank you, Team Indias. Thank
Sincere
you.
request to all the Kasoga dignitaries who are going to vote. Please cast your vote in favor of Monica. She's a very well-deserving candidate, very hardworking. I request your support for her.
She is a very polite and very nice, approachable person. She's a sweetheart. You will win, Dr. Monica. Good
Thank
luck.
you, Lavanya. Thank you so much for your love and
Rekha,
affection.
yes, we pray for your success.
Thank you. Thank you, Rekha ma'am. Thank you so much. Thank you, madam. Take care, Rekha ma'am.
Yeah.
Take care. Stay
I
strong. Take care.
Since there was lack of time and you had told me to take only first few cases, so I had to stop. Thank you.
Oh, no,
Anyway,
you are a very strong person, ma'am. Very strong. Thank you so much. Take care, ma'am.
Good night.
yeah. All the best. Good night.
No,
Good night.
all a night and have a great week ahead. Thank you. Thank you.
Yeah. Bye. Bye.